instructions before we start. We request all the dignitary speakers to kindly stick to the time. We also request the chairperson and speaker to collect their memento at the end of the session from the registration counter. Question and answer will be taken at the end of the session. And with all this few basic instruction, me, Dr. Nikhil Lohia, and my partner, Dr. Rizwan Ahmed, we welcome you all. So we move on without wasting further time to the first session, for which I would like to invite our chairpersons, Dr. Anand Bhutra sir, Dr. Sanjay Panjwani sir, and Dr. Pritesh Khatwar sir for the session. Sir, please welcome.
Hello everyone. You are all are welcome in this today's Pediatric ALLERCON 2022. Today is a session number 1, in which I invite Dr. Dhanesh Walkoir sir from Goa. He will speak on the topic approach to in vitro diagnosis of allergic diseases. Dr. Dhanesh Walkoir sir is from Goa. Sir has done his MBBS, DCH, DPH, AFIH, and he is practicing in allergy and pediatrics. Now I invite Dr. Dhanesh sir.
Hello, good morning and warm welcome to all of you. Thanks organizers for giving me this opportunity to speak in front of all of you. This is going live also, I've heard, on YouTube, and link will remain. So even if there are less audience, everyone can view this. So there's no issue, even if the people have not woke up, this will be there. Every session will be there live. Every session will be there recorded also. So anyone can look into it. So, my dear friends, once again, I thank the organizers for giving me the opportunity. And let's do the opening. So, all of you are eager to know whether there is a single blood test, a simple blood test available for diagnosis of these allergic conditions, which pediatricians see right from the birth or immediately after birth in very early period to the adolescence, and then it goes on. The worst case scenario for them, for these children, will happen later on in the life when they will go in the hands of adult physicians and pulmonologists with asthma and so many other things. And what we can do, but how we can investigate, and where does the market lies. It's being flooded with all this type of advertises, and they've been targeting even a general populations, and then also doctors with so many things. So nothing else these people do, that they just make the money and nothing else. These are ELISA tests, or some people just do the blood collection and don't do even analyze. With 2,500 rupees test, you cannot do 200 antigens, and they're sensible. What happens to the patients ultimately? They'll end up in a malnutrition or avoiding so many foods, and then they come to you and they never have an answer. And not only these people, there are sophisticated labs who says that they've got a shortcut. They have designed their own protocol and giving you in the hands of pediatricians and all. And they say that there's a cardiotop test, which is a screening test, and you can solve it, whether it's allergic or not, with just 1,500 rupees test and all. And then they inform you to go for a next panel, which they have designed. And again, it costs around 10,000-15,000 rupees, and nowhere it lands up to you where exact diagnosis is there or not. And nowadays, another 15, 16,000 rupees test, so people come with this IgG test, so far called as intolerance test, which forget about it, they have a role in allergy, which patient comes with you all this protocol and tests, but they don't even have a role in intolerance. IgG is not the marker for intolerance. IgG4 comes up when immunotherapy is working. IgG has got no role in intolerance. And what you're supposed to do in intolerance, what works is you should your history and then remove the offending food. That's just remove it and then elimination diet, and your patient will improve. The same thing happen even if it's an non-IgE mediated allergy, which again manifests with the same GI symptoms. And here also you need to eliminate the offending food item, and it will improve. And there is no diagnosis of specific IgE test or anything for allergy. So these things you need to evaluate, enumerate, and then go to your test, whichever you like. So this is the full spectrum of allergy, which everybody is looking for, and everything doesn't have a blood test. Urticaria, angioedema, for example, chronic one, is completely different type of disease, a mast cell disease, and not an IgE mediated. Every drug allergy is should be evaluated only by the blood test. There are, for IgE mediated infections, IgE mediated conditions, if you are dealing with, then definitely yes. And what we are going to look up for is IgE mediated infections and how to deal with it. That's IgE mediated allergy. You carry it on the background of family history of allergy most of the time, and lack of normal deliveries. And then you get some gastrointestinal disorder symptoms in very early childhood. Many of the time it is a milk allergy, milk protein allergy, then atopic dermatitis, eczema, wheezing in infancy, or then in childhood, early childhood, and then allergic rhinitis, and it goes on, and again it remains. So here, something has to be done, and march has to be halted. And that's the reason early detection of the causative allergen is important and has been recommended by all the agencies. So what we have to do, most important thing is history. History is the most important thing in clinical examination to know what test to be done. And this is a diagnostic pyramid, which we stand most is the down here is a medical history. It takes around 45 minutes or more to evaluate the patients when they come for you to analyze for the allergy. And then only you can diagnose or decide what test to be done. And most of the time, it is skin prick test. And very few time when we decide some in vitro test, which will come and inform in next few minutes for those who know the allergy. Those who do not know, we will give you some clue about what test can be done. But the final diagnosis of allergic condition, IgE allergic condition, is always by provocation test or by challenge. You give that offending antigen and you develop a reaction right in front of you, whether it's minor or major one also. It's not as simple as that just giving a piece of egg and developing a reaction. It may be a severe reaction also. It's a graded one. It's a completely different scenario. So let's learn what we can do. So blood test and a skin prick test. Why I've said here, because for both, we are testing a IgE. That's an antibody developed to an allergen, which is an offending antigen. And here, the allergen sits on a mast cell. And then when the antibody sits on a mast cell and allergen comes, and that time antigen-antibody reaction comes up. And that has been elicited exactly in the skin prick test. But what you do when you do the blood test is there are floating antigens, floating antibodies, the IgE antibodies. So here the sensitivity may not be accurate as skin prick test because they go low. There's not a free circulating one and not a bound one. So the efficiency and it goes down. So when you are needed in vitro diagnosis, so most of you who like to know and those who are not trained in allergy, the last indication is more important. That's doctors not trained in skin prick test, and can they be helped? Those who know it have got a little bit role, like when you don't have a place like on an arm or back because of eczema, or cannot stop the antihistaminic, which is a prerequisites, or even for many other reasons, including immediately after anaphylaxis, because it takes about 6 weeks before you do the skin prick test. And what test most of your patients or GPs and all, they look out for eosinophil, which is a marker of allergy, but many a times eosinophils can be normal and it will not identify it as allergic infection only, even if there are absolute eosinophilia or vacuolated eosinophils, because there are many other conditions which give rise to this, including the parasitic infection, which are still common in the rural areas and all. And if it's a very high, you may be dealing with a hyper IgE syndrome or neoplasm or malignancies and all. So then next comes a total IgE. Is this test going to solve your problem? Again, what we are looking after, we are supposed to look after in diagnosing allergy is a IgE to particular antigen. That's a specific IgE, and which is a minuscule part of a total IgE embedigo. So total IgE can be raised in many conditions. It's always raised in most of the patients just because of environmental pollution, diesel exhaust, or smoking. And when you are dealing with a very high IgE, more than 100, there are norms where it's increased, and your report will say the increase with the very about 100 and all. But when it goes in thousands and all, everybody feel like it's an IgE, and it is usually not. And you may be dealing with something like hyper IgE syndrome or neoplasm or atopic dermatitis also. It goes very high. It may be increased in IgE condition also, but there are many other conditions. So there are 50% more than 50% chances that in allergic condition, it may be raised or it may not be raised. So your answer should lie in a specific antigens. So specific antigen, if you are looking out for an egg allergy, then you do serum specific IgE of egg only. And how you are going to ask for this? Because lab also now provided with different type of tests. The three important machines that are available all over the world are this, of which the ImmunoCap is one of the gold standard, and it is available in India. So you have to ask for a serum specific IgE of particular antigens by ImmunoCap method. And how you interpret it, because your report will say if it is more than 0.35, then it will be recorded as a positive, and it is positive. But what is it? Where does it stand, this positivity? In this graph, the positivity of the S-shaped graph goes from 0.35 to above 100 in S-shaped curve. And more the value, higher the value, higher is the risk of allergy. It is a sensitivity, not a clinical allergy, where allergy has to be diagnosed in the context of clinical scenario. Only if it clinically it is related, then only you can say there is an allergy. So if it is very low, take it for the pinch of salt, it may not be allergy, even if it's ImmunoCap. So many of them may come positive here. If it is in a single figure, somewhere more than one, don't say that it is not, please evaluate it properly. And about double figure, it's more likely, just cannot neglect it. And if it's more than 100, which we get many a times in a highly allergic individuals also. This grading and chart is not a standard one. Nobody has designed a standard one, because there is a lot of issues dealing with this IgE test also. This is just an arbitrary conditions. So what allergens you are going to ask? Your most important allergic condition for the respiratory allergy is due to dust mite. About 70 to more than 70% everywhere in India. And in coastal areas like where I stay in Goa, Mumbai, Chennai, it could be even up to 90% and more because of the humidity, which dust mite likes to stay in, and many other conditions. So you have to ask for a dust mite ImmunoCap serum specific IgE test by ImmunoCap, and which dust mite. There are many more, but three are important, which are written here down. They are important in India everywhere. But most of the standard lab, which do the ImmunoCap, they do only of diphtheria and terinosis type of immunotherapy. They feel that blomia is not there in India, because these two are common in Europe and America, and blomia is quite a lot in India, and you have to include the blomia. I told those labs that include it, but they are not doing it. It is available. And very few allergy clinics or allergy clinics who does the very high-fi work, they do blomia tropicalis serum specific IgE. We should put the pressure on them and somehow to include the blomia also. And if they can give us a package of only these three antigens, and at the because each antigen costs around 1,500 to 1,500 rupees. So within some, and they group some antigens and give you a little lesser package. So if you give only these three, and you knew patients who wheeze, children who wheeze again and again, who may not require immunotherapy, may outgrow with the time, but the quality of their conditions will improve only with the environmental control if you deal with the house dust mite. So remember, in the coming days, remember the house dust mite and learn maximum thing about this one antigen, which is crippling the pediatric patients for their routine allergy issues, that's wheezing and allergic rhinitis. So which other antigens you would like to add? If the child is indoor, a smaller child, then you need to have some few indoor antigen which you can do and you can add. And this is not a panel, but you own design. So there are companies who gives any 5 or any 7 or any 10, but each will cost you about 1,000 rupees or more. Then include all three mites, few molds, 1 or 2 or 3, 2 or 4 molds as I have shown here. Animal dander is usually not seen so much. Few of the Persian cats and all I have seen. Dog also was not seen much, very, very less in India, but the mites are very well known. Molds can be there. Insects usually come positive, but many of them it is a cross reactivity to mites. And food only if there is a specific history and based on the clinical scenario. And when the child is more bigger age group, going to school or even 7, 8, 9, and later on, if they are having allergic conditions, then add pollens. It depends on region and season. Which one from this particular area will get an answer after Dr. A.B. Singh's lecture, which you will hear in a course of time. And is there any scenario where you know that this serum specific IG can be very useful? See, there is not much definite guidelines, but this one Samson and et al. Has shown, and Ben it's been quoted very well in the world in most of the literatures and studies, that these figures, which I have shown here, if they are there on the specific IG, the positive predictive value is more than 95%. And they say that oral challenge, which is the 100% diagnosis, may not be required in this case. So if the milk is having more than 15 or egg more than 7, you may not do the blood oral challenge if clinical scenario is very, very related. Similar thing is for less than 2 years, is milk is 5, which is a very common scenario in pediatric age group, in a very small age group. You have got a gastrointestinal symptoms and could be a milk allergy. So for you to diagnose when skin prick test is not available with you, but it's not an answer for that, because most of the time this milk allergy in a lower age group is non-IgE type. So serum specific IG will be totally negative. And how to deal with it exactly and how to evaluate the case, we will get an answer in Dr. Arif's lecture, which will come up in the course of this conference. So oral food challenge is a diagnostic for food allergy. An allergy test comes in between, can be evaluated on the basis of clinical history, and you can come to some conclusion. For diagnosis required oral food challenge, and they are difficult because oral food challenge, you require to be given very small amount and gradually increasing in a control setup, in ICU setup, because anaphylaxis also can occur. So in time to come, can you have an answer? Could be. Basophil activation test is like doing allergy oral food challenge in a test tube. You stimulate a basophil with CD cell, and exact reaction can be produced. But here, when you are doing this test, it is in the research phase as of now. You have to immediately remove the blood and put in the system, and that systems are also not available. But the way the things are going up from nowhere nowadays, a new innovation, I hope that this also will come in the clinical scenario in time to come. Thus, a drug allergy has got a role. See, serum specific IG is available for few of these antibiotics and insulin and other things. It is not there for NSAID, important thing, but how to evaluate drug allergy again. Serum specific IG may not, positivity may not confirm the diagnosis, and negativity also will not rule out. So it is not a shortcut. There is a stage wise how we can go for it, but there will be some clues if you know, because these are the antibiotics which usually give rise to allergy and all, and most of the time it is a false results, and everybody is off those antibiotics or other things, maybe because they have got a rash, which is a viral rash and all. How this answer can be given to drug allergy, Dr. Sitesh is going to tell us in course of the time in this conference. So everything has got a detail and proper protocol wise you can go. This one serum tryptase, which is raised after anaphylaxis or acute reaction, may help. It cost is a problem. and short half-life, cost about 6,000 rupees and all. So when you are having this acute allergic reaction, or something like acute angioedema or acute reaction coming up again and again with a drug or any other food also, you can tell the patient that whenever this thing comes up, you collect the blood immediately, because the half-life is very less. Within 60 minutes, it can go up. So you have to collect the blood within 2 hours, so within 2 to 4 hours, 15 minutes to 2 hours, and analyze it. But analysis again is an issue in India, because alpha tryptase is analyzed in India, not the beta one, which is a better indicator. So these are all the logistic and other issues remain, but still it could be an answer. Then you will ask me that you said about the Fadia top. What is the indication for the Fadia top? Is an immunocap specific IgE method only. What the company has done in India is that they have included 5-6 antigens for both age group, for children and the adult, and then they mix it up and give you the answer. So if it is a mites, which is, I told you about 70-80% will be positive. So it will be positive here also in Fadia top, and they say that 80% is a screening test, 80% will be positive. It's not an ideal scenario, not validated or recommended by any of the guidelines or any of the agencies. It's a gimmick being played in India by the companies, and then they say to how they have those panels. This is basically because most of our pediatricians, they have not looked at the allergy in a proper sense, how to evaluate it. Thanks to Dr. Rajkumar for getting this conference here, and many of the people in this region will now come to know how we can go about. And then the market is now flooded with something called a CRD, component result diagnosis test. And these are again about 15,000 rupees or 16,000 rupees test, has got a limited role, because here instead of specific IgE, they have dissected that particular antigen of mites further into about 20 to 30, more than 20 antigens, and 1 or 2 of them are the one which are highly sensitive. And you may get an answer with the cross reactivity and all, because you can specifically target your immunotherapy based on this, or may have an answer to something like exercise-induced anaphylaxis, where 1-ω-gliadin can give you a diagnosis with a wheat antigen. So something like that came up. But today, instead of single antigen, what is available in the market is about 200 to 250 antigens, micro antigens, and going 50-60,000 rupees, and about full test you are getting. So how the application can be done here again, Dr. Kashyap is going to tell us more about this CRD in the conference later on. So my dear friends, for you, the take-home message is we can evaluate the allergy. What's more important is a clinical history. Very few of these tests are required, and absolutely CRD or molecular allergy has got a very few role for those in the expert hands. I think if we can do it and listen to the conference forward 2 days, many of your answers will you get, and you can give your patients allergy immunotherapy-free life. Thank you very much. So hope I finished in time. Thank you.
Thank you, Dhanish sir, for your enlightening lecture and very informative lecture on approach to an in vitro diagnosis of allergic diseases. From audience, if any questions are there, they may ask. No questions?
Thanks, Dr. Dhanesh sir.
Okay.
We will move for the next presentation by Dr. Rushali Varad. She has done fellowship in phacoemulsification, cataract surgery, eye disease, squint retina, glaucoma from Lakshmi Eye Institute, Mumbai. She is DNB from Mumbai University under care of Dr. R.C. Patil. She has also done glaucoma fellowship from Arvind Eye Institute, Madurai, and she is director Sai Allergy Asthma Eye Hospital at Pune. So she will be delivering a presentation on how to approach and treatment of common eye allergies. So over to you, ma'am.
Good morning, everyone. First of all, I would like to thank organizing and scientific committee for this wonderful opportunity. So I'll be speaking on approach and management of allergic eye diseases, and most common is then allergic conjunctivitis. So I'll be speaking more on the allergic conjunctivitis. So what is allergic conjunctivitis? It is not a single entity. This includes, it is an umbrella term. It includes distinct clinical entities which can be mild, but that is disturbing for patient, and that can be a severe inflammation involving the cornea, and that can lead to an blindness too. So this is something serious. Why it is common? According to World Allergy Organization, around 95% of allergic rhinitis patients have an associated involvement of conjunctiva or involvement of eye. So that is because of the different reason. One is its anatomical association with the eye. We know that eye and nose is connected with a nasolacrimal duct. You can see in this picture, there is a nasolacrimal duct in between eye and nose. So epithelium is in a continuity. Conjunctival epithelium, nasolacrimal duct epithelium, and the nasal mucosa epithelium are in the same continuity. So in a respiratory, you talk about the same airway, say one airway, one disease. So same way, this anatomical connectivity of the eye and nose gives is an involvement of eye in a rhinitis patient. But unfortunately, most of the patients are not diagnosed or underdiagnosed. So they come later on with either complication that could be a disease related, or that could be a medicine related complication. Why I'm saying medicine related is, we all know for the allergy, what is medicine or which medicine patients are responding is the steroids. So over the counter, many patients take a drops, they feel better with it. Again, they use it at home themselves, and later on they present with an steroid-induced cataract or steroid-induced glaucoma. So whenever patient comes to allergist or pediatrician or with an rhinitis patient, do ask about the involvement of the eye by asking them an ocular itching or watering and photophobia, and also ask them whether they are using any drops. So we can guide them to consult the ophthalmologist, and we can prevent the medicine-induced disease. Again, there is a nerve connection between eye and nose. So that is why there is an nasoocular reflex. Parasympathetic input is common in between. So whenever in a rhinitis patient, they are symptomatic with rhinitis, patient comes with an itching also. The symptoms with the patients are symptomatic with eye disease, eye complaints also. That is because of the nerve stimulation. Even though eye is quiet, but that itching can lead to an ocular complication. I'll explain in a further talk how that is bothering the patient. So it is common because of its anatomical position. Eye is continuously exposed to the environment and presence of abundant of a mast cell. As we all are aware, for an allergy, we need a mast cell to stimulate the cascade. So in a conjunctiva, around 5,000 mast cells are present in a per cubic millimeter area. And also conjunctiva is a highly vascular structure. So this is how it is classified. Same as an allergic rhinitis, this is also seasonal, perennial. But what is bothering is a more chronic form of allergic conjunctivitis, that is a vernal keratoconjunctivitis, and second one is atopic keratoconjunctivitis. These vernal and atopic are common in all signs and symptoms, except in atopic, it is associated with the atopy or the skin involvement. GPC is not a true allergic conjunctivitis. This is secondary to the contact lens, but to complete the talk, we have done this. So I was telling you in the definition how disturbing mild ocular conjunctivitis also. So look at this child. He is around 4 to 5 years old child. He is having a moderate allergic conjunctivitis. I'm asking him to look in front of the camera, but unfortunately, he is not able to focus. And that is because of his corneal involvement. He continuously keep on itching and rubbing his eye, and that is causing damage to his epithelium, and that is leading to an photophobia. Now, how this disease can be blinding? So what happens in allergic conjunctivitis? Anatomically, it is divided into two types. One is tarsal and second one is limbal. So in the tarsal allergic conjunctivitis, you can see your normal normal on my right hand side, this is a normal tarsal plate, and on another side, this is a normal tarsal plate. This is a normal tarsal plate, and this one is an inflamed tarsal plate. So this is in cobblestone appearance of a tarsal plate because of the inflammation of the conjunctiva. Just like a cobblestone appearance you get in the throat also in allergic patient. So same way there happens an inflammation and leads to cobblestone appearance of the tarsal conjunctiva. So what happens every blink, this papillae or the giant papilla, it rubs to your cornea, and that damages the superficial layer of the cornea or the epithelium of the cornea, leading to punctate keratitis, that is called as a superficial punctate keratitis. And if we don't treat it in a time, then this can lead to an ulcer. There is a degeneration of the epithelium, and this causes an corneal ulcer. This is called as a Shields ulcer. This is specifically seen in an allergic patient. So this ulcer here also, this green stain isn't because of the ulcer. So this ulcer can get infected, can get further aggravated, and that can cause a vision disturbance. Or sometimes we need to change the cornea too. This is another form of an allergic conjunctivitis that is called as an limbal. So here inflammatory changes occurs around the limbus. So here where the stem cells are located, because of the repeated inflammation, that we get a deficiency of the stem cells, leading to an opacification of cornea. So this is a severely inflamed limbal allergic conjunctivitis patient. So this is how this allergic conjunctivitis can be blinding. This is another disease called as an keratoconus. In these patients, eye may not be inflamed. Just because of the itching also, patient can leads to this complication called as an keratoconus. This is a cornea. Because of the constant rubbing or the itching, there occurs a thinning of a cornea at one place and a bulging of a cornea at another place, leading to an irregular shape, irregular astigmatism. Sometimes this inner layer can get ruptured, leading to an head drops. In such patients, we need to change the cornea by an keratoplasty. So this is how allergic conjunctivitis is blinding. Now, is this blindness preventable? So yes, this is a preventable type of blindness. Some blindness, unfortunately, we cannot prevent, or some are by birth, but this blindness is preventable. And this needs attention with the same clinical gravity as other allergic diseases are taken with, such as the asthma or allergic rhinitis. So consider allergic conjunctivitis also as severe as an allergic asthma or allergic rhinitis. So now how to approach this allergic conjunctivitis patient? It needs management at multiple level, at systemic level and at local level also, at ocular level also. So first is we should control the inflammation at both level, systemic as well as topically. Then find out the causative allergens that is causing the allergy. And third one is the prevention of the further inflammation by increasing the tolerance of the patient by giving an immunotherapy. So how can we control the inflammation? There are multiple drugs which act at different levels. Some drugs at a mediator level. We all are know systemic drugs, and in a further talk, they will explain about this also. But topically also, these drugs are available to control the disease. Drugs which acts at a mediator level, drugs which act at an effector level. This we know that monoclonal Ig antibody, then mast cell stabilizer, and steroids. But these are all a symptomatic control or the control of the inflammation. But to prevent the further progress of a disease or the disease modifying treatment is none other the allergen or the allergy avoidance, allergen avoidance, and the immunotherapy or increasing the tolerance of the patient. Now look at this patient. This is a 7-year-old boy referred to us in April 2021 with a typical complaint of redness, watering, and photophobia. Photophobia is an intolerance of light. This is with the both eyes. Right eye is more than left eye. He was already diagnosed with an allergic conjunctivitis since 4 years. He was on all possible treatments with an ophthalmologist, with an local steroid drops, local antihistamines, local mast cell stabilizer. But he was progressing. He was not responding to the treatment because root cause management was missing. You can see here, he has been advised supratarsal injection here and bandage contact lens to heal the ulcer. What is supratarsal injection is? We give an steroid injection, tarsal plate. So as this was a kid, it was little difficult. I'm not saying it is impossible, but it is a little difficult to give an injection in the eye. These were the his presenting features. As disease, he was very uncooperative. His vision was affected a lot. It was just he was just telling a finger counting vision. Then there was a presence of a conjunctival congestion. Then there was a giant papillae at the tarsal plate. Then there was a shield ulcer with the right eye, and his intraocular pressure and fundus was normal. This was after treatment. He improved to 6.9 with this type of refraction. He was having a corneal opacity, and after the healing of this ulcer. So this is a normal plate. He was having a such type of inflamed tarsal plate. This was a corneal ulcer. This was another cornea that was a normal. So how we managed? We prescribed oral montelukast and levocetirizine, and to reduce the inflammation faster way, we gave him an injection omalizumab. We all are aware about what is omalizumab. It is a monoclonal Ig antibody. It was given in a 4 dose at the interval of 1 month and treated locally also with the help of bandage contact lens to heal the ulcer, along with the low potent steroid in a tapering dose, then tacrolimus eye ointment and CMC eye drops. Along with that, he was prescribed or he was guided for the allergen avoidance, nasal wash, and immunotherapy also. So skin prick test was done. He was positive for this type of allergen. As Dr. Danish told, IgE is not a diagnostic, but we, an academic purpose, we do it in such patients. This was around 346. So this is after injection, how gradually this giant papillae goes on regression. This slides you can see. This is how after first injection, second injection, third injection, and then in the last slide, I'll show you the comparison after in the first and the fourth injection of the omalizumab. So gradually this inflammation was decreased and it was maintained with the help of the other medicine afterwards. This is how this corneal opacity after healing the corneal ulcer, this was a corneal opacity. So this was a second case. He's a 20 years old male, came to us in September 17, complaining of typical complaints, redness, pain, watering since 17 years. So now please make a note this, he is symptomatic since 17 years. So why I am taking this case is most of the times we guide patient ki this allergy will go off as age will increase, but things are not like that. Many of patient carries this disease in a adulthood also. So this patient was symptomatic since childhood. Now then he started getting skin rash since 4 years. So this again explain about the march, allergic march. First there was an involvement of eye, then there is an involvement of skin atopy. Then he was on a lotipred. He was using himself twice a day, sometimes once a day, and CMC twice or once a day. Then these were the clinical features. What was a positive finding here is he was started getting a high intraocular pressure. He was starting getting a glaucoma because of the repeated or the long use of the steroid. So this was his old report. You can see this is reported 2011, and that also time it was recorded giant papillary conjunctivitis. So since this time he was a giant papillary with his eye, and he was carrying this disease since so long. This was his presentation. These were the giant papillae. This were the SPKs. There was no ulcer, fortunately, maybe because he was using a CMC eye drop and he was not rubbing that much. So he was having a just superficial punctate keratitis. There was an hypertrophic turbinate with the nose. Then again, allergy testing. This is an IgE level. IgE level was quite high in this patient. Then we treated with an oral fexofenadine and montelukast. Then again, we advised him, and he took it omalizumab, 4 doses at the interval of 1 month. Then nasal steroid has a good role in ocular allergic management because it reduces the nasoocular reflex also, and it takes care of the nasal turbinates also. Then locally, he was prescribed with lotiprednisolone in a tapering dose, cyclosporin eye drops, and other mast cell stabilizer to reduce his pressure. Timolate was given, and allergen avoidance and immunotherapy was prescribed. This was the first picture at the presentation. You can note the skin rash here. This was the last picture after the treatment. This is how omalizumab works on. I think this will be covered in the next talk. It binds to the Ig and prevents the binding of it to the mast cell, so that further cascade of the allergy it stopped here itself. So what is the aim of the treatment in a allergic conjunctivitis? First, patient should be comfortable, because we in a first video only I explained how uncomfortable it is, and mostly around 40% of children are affected with allergic conjunctivitis, if you see. And this is an growing age. At this age, they have to attend the school, they have to go out, social activity. So this bothers them while studying, while playing out. So first aim is to make a patient comfortable, and by improving the quality of a life by treating a root cause along with an topical management. Then prevent the patient to go in a stage of a complication, that is, and disease related complications also, and medicine related complications also. Then prevent the medicine induced complications. I explained about the steroid induced glaucoma and steroid induced cataract. Repeated and overuse of cataract and glaucoma causes the, repeated and overuse of steroid uses the cataract and glaucoma also. Cataract, we can operate, we can place a lens and vision can be regained. But again, there's a loss of accommodation. It causes a limitation specifically in a pediatric age group, but glaucoma is not reversible. Once it damages your optic nerve, then this is a not reversible blindness. So we can very well do it by proper guidance to the patients. Then we can aim to not only just a temporary treatment, but also to stop the allergic march. Study has been done. Patients with an allergic conjunctivitis who is treated with an immunotherapy are less children are going in asthma in adulthood. Few papers are there how immunotherapy given to the allergic conjunctivitis patients can help to prevent the allergic march also. So this is a step ladder management of an allergic conjunctivitis. In a 0, we don't give any treatment. In a grade 1 and mild cases, we give an occasional anti-allergic and topical drops, lubricating drops. In a moderate, we use low potent steroids along with an anti-allergic medicines. But in a moderate stage itself, it is beneficiary for the patient if they do an allergy testing and immunotherapy, so that we can prevent the patient going in a more severe form of the diseases. So thank you. This is all about the allergic conjunctivitis. I would like to take any questions.
So if there are any questions, yes, please. You can use mic.
You must be having quite a lot of experience of giving immunotherapy also.
Yeah. Actually, I'm fortunately immunotherapist at my right hand side, so I'm quite fortunate about it. So I'm lucky to have an immunotherapist to stand by with me. Yes, please.
So How many you have done till now?
What
This is,
allergic and
immunotherapy,
Omalizumab?
immunotherapy. And what's your experience on that?
See, moderate, mild, though we don't, just we make them aware about the testing and immunotherapy, but unfortunately in a mild cases, they don't treat with. But in moderate cases, now patients are, converting to the immunotherapy, and it's in severe, around allergic conjunctivitis, around maybe 150 to 200 patients we are having with an immunotherapy. Not only mine, but other ophthalmologists are also referring to the Dr. Vijay. So he is managing that also. So if we collectively you ask me, around 150 to 200 patients are on immunotherapy. And if you ask me about the omalizumab, around 4 patients we have given omalizumab. These the 2 I explained, and 2 more were there. We given omalizumab to 4 patients.
So this immunotherapy, many of them are purely only allergic conjunctivitis, do not have rhinitis and asthma and all.
See,
Yeah.
patients who is referred from the ophthalmologist, they are purely with a severe allergic conjunctivitis. So in allergic, one or the other disease is more symptomatic. So in allergic who has an VKC and EKC, they are more symptomatic with the allergic. So same patients are there with an VKC and EKC. They are more bothering about the eye diseases. So associated, they have history, previous history of a rhinitis or other skin involvement in the childhood, but more they are presenting with a severe form of VKC.
Thank you.
Yeah, thank you. Thanks, sir.
Well, thanks, ma'am, for enlightening us about this relatively common topic, but can rarely be severe enough to require higher medications. Yeah, please, sir.
On omalizumab, the patient may need it forever. The benefit and advantage of instituting immunotherapy is that you can shorten the course of omalizumab, maybe to about 6 to 8 months. And then by that time, immunotherapy takes over, and then you can stop omalizumab and continue only with immunotherapy, and patients will do very well.
Thank you, sir.
A gentle reminder, at the end of the session, we'll have a photo session here. So all the dignitary speakers are requested to stay
Just,
back.
sir, you said very well. Sorry to interrupt. You can continue. Sir, you said very well. That patient, what first case I was talking about, 7 years old boy, he felt better, his corneal ulcer healed, and he lost follow-up. But again, his symptoms started on. But omalizumab being a costly, every time we cannot, but he started with immunotherapy, then only with immunotherapy also his disease is controlled now. So what is important is, along with that, to start desensitization also. Yeah, so we can reduce the further doses of an omalizumab. Thank you, sir.
So we'll move to the next topic, which is very common to pediatrician, but very commonly mismanaged also. That is atopic dermatitis and its topical management. For this, I may call upon the stage Dr. Krishna Mohan R. Sir. Sir is a MBBS, DNB, Diploma in Allergy and Asthma, MNA, MS. He is a consultant in pediatrics and pediatric allergy with the Kerala Government Health Services. He is a state chairperson, respiratory chapter, IAP Kerala. He is an editor, treasurer of National Allergy Chapter, Central IAP. Sir is a National EB member, respiratory chapter, Central IAP for 2021. He was state joint secretary, IAP Kerala 21-22. State chairperson, allergy and applied immunology chapter, Kerala for 2019-2020. He is best academic activities award recipient 2016 from IAP Kerala. Sir received state level best doctor award 2019 from Kerala Government Medical Officers Association. Sir was a chief editor essential of pediatric allergy and applied immunology, Nobel 2021. He is associate editor textbook of pediatric allergy and applied immunology, Micro Publishing House 2020, allergy and applied immunology chapter, Central IAP. He is academic editor, Partha's Handbook of Pediatric Adolescent Practice, JIP publication. Over to you, sir.
Thank you so much for the nice words. A very good morning to all of you. At the outset, let me thank the organizers, IAP Nagpur and IAP Allergy and Applied Immunology chapter of Central IIP for giving me this wonderful opportunity. So as Sir mentioned, today I'm going to discuss in the next 20 minutes about a very common topic, management of atopic dermatitis. And Dr. Rajkumar sir has told me that I should finish it exactly at 20 minutes. And the topic is only topical management. So I won't be talking anything about the systemic management. So why should we discuss this topic, as it is a most common chronic relapsing skin disease seen in infancy and childhood. And all of us know, especially the practicing allergists, we will be seeing a lot of cases of atopic dermatitis on a daily basis. And the basic pathogenesis, atopic dermatitis is having, is a defective skin barrier with a reduced skin innate immune responses and a polarized adaptive immunes. Polarized means, as like in any other allergy, there is a polarization to the Th2 type. So basic pathogenesis is, the most important thing is the defect in a filaggrin gene. The expression of filaggrin and ceramide decreases in skin with atopic dermatitis, and it is considered as the primary cause. And the three cardinal features: itching. Itching is the most important thing and the most distressing symptom, cirrhosis and skin lesions. And the itching, what it is usually said, it is a itch that rashes. Unlike the many other itching conditions, the itch comes first and then only a rash comes. So the itch will initiate the rash by release of pro-inflammatory mediators. With this, I directly go to the treatment, topical treatment of atopic dermatitis. So atopic dermatitis, we have non-pharmacological management as well as pharmacological management. And it can also be classified as topical management and systemic management. So I will be discussing only about the topical management. So starting with the topical management, before we start any topical management, most important thing for any allergic disease is avoidance of triggers. So here also, we need to avoid many of the triggers, the aeroallergens, and especially house dust mite. This Danesh sir was talking today morning about house dust mite, cockroach and all. So we have to do a proper wet mopping, a regular vacuum cleaning, and no tobacco. Tobacco is a very, very important allergen as well as irritant. And there should not be any rugs in the bedroom. Pets also should be avoided, especially cats. And what about foods? Food restriction, empirical food restriction is not recommended, only if by taking the history and doing a immunocap or skin test, if you're getting a specific food allergen is causing the problem, then only we need to restrict the foods. Now coming to clothing, what all things we have to take care in case of atopic dermatitis. So what is recommended is that any child with atopic dermatitis should only wear cotton clothes. That is the least irritating type of fabric that you can use. And if the child is so particular that he wants to use a synthetic dress, then make sure that he's keeping some lining of cotton inside. And wool and woolen clothes are very, very irritant in nature, and always take care to avoid woolen. And always avoid tight fitting dresses. And what about bathing? So bathing is very important. There are specific recommendations for the considering the bathing of an atopic dermatitis child. So such children should bath at least once a day, and the temperature of water is important. What is recommended is to use a lukewarm water, and the bath should not be prolonged. So we usually have a misconception, especially the patient, there is a drying. So keep on bathing and keep on bathing several times. That will do a damage. So you are advised to use lukewarm water, and the time advised is maximum 5 minutes, 5 to 10 minutes, and preferably in daytime. And moisturizer, I will be discussing it later, and that has to be applied within 3 minutes after bath while the skin is still moist. And the next important thing is about soaps. Which soap to use? So this is one common doubt parents will be having. So when we consider the soap to be used, the most important thing is the pH of the soap. So we should understand that the common soaps that we are using, the common bath soaps that we are using, most of them are alkaline. And the skin, the physiology of the skin is such that the normal pH is about 5.5 to 6 in that range acidic pH. So in atopic dermatitis, what is advised is that you should not use alkaline soaps. So you are supposed to use mildly acidic soaps. And bathing also, you have to take care how you take bath. You have to clean thoroughly, but gently, thoroughly and gently. And you should avoid strong scrubbing and rubbing, and avoid perfume soaps. And these are some modified versions of soaps. It is synthetic detergent. It is not actually a soap. So even though it's costly, but for an atopic dermatitis patient, a syndet will be better than using a soap. So the advantages of using a syndet is it is having a neutral to low pH. They are hypoallergenic, non-irritant, and fragrance-free. They should be like that. But nowadays, even the syndets are coming with fragrances, but ideally it should not have. Now coming to the most important part of the topical management of atopic dermatitis, it is moisturizing. So if you ask me what is the most important part of management, I would say moisturizing, moisturizing, and moisturizing. So drying is one important thing which is causing majority of the symptoms of atopic dermatitis. So naturally you have to give moisturizing. So the regular use of moisturizer is the core of the management, and it should be part of all stages. Let it be mild, moderate, or severe, you have to use a moisturizer regularly. So it replaces the water loss from the skin, it can lubricate the skin, it reduces the scaling, and it seals the stratum corneum. And the vehicle in which you are using the moisturizer is also important. Many times the patients will be having a confusion. If you are using some sort of moisturizers, what is wrong if you use it in a lotion? What is wrong if you are there? For a patient, everything is same. They look only for the brand name, but it is different. If you're using a cream, if you're using a lotion or an ointment, the strength, the mechanism of action, everything will differ. So creams are, ointments are comparatively, as the name indicates, very, very oily and sticky. They are comparatively stronger compared with creams and lotions. And creams falls in between the lotion and ointments. They are comparatively less oily, and they are the ones most preferred by the patient. On the other hand, lotions are more liquidy. They are having more water content, but they dries up fast. So it is powder in water, and higher percentage of water related to oil is there. So whatever moisturizer you are using, the regular use of moisturizer has short and long-term steroid sparing effects and reduces the frequency of acute episodes. And in simple terms, emollients increase the benefit obtained from topical corticosteroid therapy. So these are the general principles to be followed when you are using moisturizer. It should be used at least 2 times a day, 2 to 3 times a day. But when the child is having an acute flare-up, you can use more, 4 to 5 times you are supposed to use. And you tell the patient to use it liberally, at least 250 gram per week. For an adult, it is around 500 gram per week. And it should be used, as I already told, more frequently during acute phase, 4 to 5 times per day. And what is recommended is that you have to apply the moisturizers within 3 minutes of after bath while the skin is still moist. And the direction of application also is very important. These all things will look very silly, but as a condition which is very chronic and we need to treat for years together, these simple points, all these are important. So downward application of emollient is what is advised, because that is the direction of the hair growth. So it will prevent folliculitis and follicular inflammation. And coming to the classification of moisturizers, we have 3 different classes. We have the occlusive agents, humectants, and emollients. So occlusive agents, as the name indicates, they just reduce the moisture loss by creating a barrier. Humectants, as you can see in the picture, they are the ones which can attract water and increase the fluid content. Emollients add hydration from their formulation to soften and soothe the skin. So the majority of the moisturizers that we have in our day-to-day practice will be a combination of all these things, not usually a single one. They will be having different components, having an occlusive, humectant, or emollients. So what are the ideal requirements of a moisturizer? So the ideal requirement is, the first and foremost, they should be hypoallergenic, they should be less irritating with minimum preservatives, they should be fragrance-free, and contains natural moisturizing factors and ceramides. That is very important point. The ceramide containing moisturizer is what is recommended, and they should be as sustainable as possible. So some common doubts which comes. The grandmother will come and ask you, this moisturizer is very, very costly. Can I use oil instead? Can I use olive oil? Can I use mustard oil? These are sort of doubts which usually come, but you should take care that you should tell them that we are not supposed to use olive oil and mustard oils, as they can even exacerbate the atopic dermatitis, can increase the severity of atopic dermatitis. But coconut oil, especially the virgin coconut oil and the sunflower seed oil, can be used, but it is not recommended to be used, but it can be used in mild cases. But you take care, you're using a virgin coconut oil. Virgin coconut oil means it is prepared, the oil is prepared from the fresh coconut, not after drying the coconut. And what is another important disadvantage of using oil in bathrooms? This is a very common disadvantage. The patient as well as the parent may fall down like this. Now, coming to the another important drug, topical corticosteroids. So corticosteroids, as in asthma, it is an anti-inflammatory. It is a cornerstone of anti-inflammatory therapy in atopic dermatitis. So the practical points in using a corticosteroid is which corticosteroids, when to use, how to choose, and how long to be used. So it depends upon the severity, site of the lesion, and age of the patient. So we have different classes from class 1 to class 7. Class 1 is the most potent and class 7 is the least potent. So we have different classes of corticosteroids, and in children, what is recommended is that you are supposed to use decreased potent ones, not the high potent ones. So class 1, 2, and 3 are not supposed to use. You can use from class 4 onwards. And just to remember, you need not have to remember all those classification. You in our day-to-day practice, you just remember these 3 or 4 drugs. In infants, we can use hydrocortisone, desonide, and fluticasone. Hydrocortisone is the most commonly used, the least potent one, but the most commonly used, very effective. And in grown-up children, you can use these 3, and also mometasone. Mometasone is very effective. After the age of 2 years, you can use it, and betamethasone. The next question is how much? Many times what happens is that we just tell, use this cream, and the patient will be, they may not be using it, or they will be using it in a bigger quantity that is not required. So for atopic dermatitis, the quantity of steroid cream, it is what is usually followed is what is known as the fingertip unit. As you can see in this picture, it is defined as the amount of cream or ointment expressed from a tube with a 5 millimeter diameter nozzle applied from the distal skin crease to the tip of index finger, as you can see in this picture. So this much amount of cream, it is enough for treating this much area, 2 palms together. So it is enough to treat and skin twice the size of the flat of an adult's hand with fingers together. Next important doubt is how long to use. So it should be used for at least 2 weeks and then review. So there is a common practice that whenever patient comes, you use it for 3 days. But it is not like that. When the child is coming with an acute flare-up, you give it for 10 to 14 days and ask the patient to come for review. And hydrocortisone and desonide, the weak potent ones, can be used up to 1 month. So stepping down, just like in asthma, here also you need to step down. So when the desired results are achieved after 2 weeks, step down the strength of steroid, or you can use it intermittently. For example, if you have started the patient on mometasone cream, after 2 weeks, the patient has come to you, but still the lesions are there, but the child has improved a lot. Then what can you do? You can step down it to hydrocortisone, or you can do it to desonide, like that. So that is about the topical corticosteroids. Now coming to another important group of drugs, the topical calcineurin inhibitors. It is approved since 2002 for atopic dermatitis, but still, especially in pediatrics, it is very, very rarely used, but it should be used more. It is actually a steroid sparing agent, and we have ointments and creams, and it is advised for moderate to severe atopic dermatitis. We have 2 formulations, 0.03% for 2 to 15 years. It is recommended to be used only after the age of 2 years. And 0.03% is for 2 to 15 years, and 0.1% is there is a stronger this thing, and it is used in adults and adolescents. Pimecrolimus also, it is coming as 1% formulation. It is also recommended in mild to moderate atopic dermatitis in more than 2 years. So it is said, or it has been found out that this 0.03% of tacrolimus and 1% of pimecrolimus is almost equivalent to a low potency steroid. Just like a hydrocortisone or desonate, it is equally effective like that. And it is so it can be used as a steroid sparing agent. In any case, you are getting side effect of a steroid, or in any case, you are not able to use steroid. Many patients will be having steroid phobia. So in such cases, you can try tacrolimus and pimecrolimus. And the 0.1% formulation is equal to that of a moderate potent steroid. They are very safe, but many a times when we prescribe, we will be having a doubt whether this is safe as a steroid. It is as safe as a steroid when properly used. The most common side effect is the skin burning, especially when you advise this patient the next day, the patient will come. Whenever I apply this, I'm getting severe burning and itching and redness is there. So is it a skin allergy to this drug? It is not an allergy. What is happening is that when you are using it for the first time for at least 5 to 7 days, there will be a release of what is called a substance P, and that is the reason why you are getting that burning sensation. But it will come down after 1 week. After 1 week, you won't be having this problem. They do not increase the risk of bacterial infection, but the risk of viral infection such as herpes simplex is slightly elevated. And one common misconception is that tacrolimus and pimecrolimus, if you use, there is a chance of malignancy. But nowadays, you do have a lot of studies which has been done and which has proved that it is very safe and the malignancy risk is not at all there. And the adverse effect, which I already told, the burning sensation. One practical thing that you can use is that you tell the patient to store the tacrolimus or pimecrolimus ointment or cream in a cold place. You just keep it in the door of the fridge 15 to 30 minutes before you're using it, and that will decrease the that side effect. And nowadays, what the recommendations are telling is that whichever drug you're using, let it be a topical corticosteroid or a topical calcineurin inhibitor, you are advised to use a reactive and proactive approach. Reactive means you are treating the acute flare-up, and proactive means just like in asthma, where you give the maintenance or controller therapy, here also once you can use the proactive therapy, that even without the symptoms, you tell the patient to use topical corticosteroid or topical calcineurin inhibitors on a twice weekly basis. Now coming to another entity called as wet wrap therapy, you can use this for both moisturizers as well as steroids. So the first step is to apply the topical agents to the lesion, and next the skin is covered with a wet inner layer of tubular bandage followed by a dry outer layer, and you can maintain this for 1 to 3 hours. In moderate to severe cases of this thing, it is very, very efficient, very, very effective. You can use this, but take care that it is done properly. If it is done unhygienically, there is a chance to develop infections like folliculitis. So if properly used, it is very, very effective. And this is another thing, especially for severe cases of atopic dermatitis, you can use bleach bath. So bleach bath, they will actually decrease the staphylococcus counts and decrease the severity and frequency of relapses. So how to give a bleach bath? 1 tablespoon of household bleaching powder, you can add it to 1 liter of water, and this solution is to be diluted to a bucket of water, that is around 20 liters of water. And depending upon the severity, you can use. For severe cases, very severe cases, you can advise to use it for daily for 5 to 6 days. And then when the child improves, you can make it alternate day or twice a week or once in a week. So this will drastically decrease the staphylococcal counts and prevents the infection. This is another modality, phototherapy. So phototherapy, ultraviolet rays are used, and it is not available in all places. I do not have any experience in using this thing, but it is as per the guidelines, it is recommended. So narrowband ultraviolet B is what is recommended. If you have a phototherapy unit, it can be used. It is costly. It comes around 10 to 11 lakhs. And the last slides, the upcoming drugs. At present, we do not have free access to crisaborole here. It is a phosphodiesterase 4 inhibitor. It is approved from 2016 onwards. It is not freely available in our place. And only 2 slides. And some drugs in the pipeline, the novel topical agents. We have the Janus kinase inhibitors, AHR modulating agents, and topical TRPV1 antagonists. They are still in the phase 2 and yet to come. So we can expect it in another 6 months to 1 year. And the most important thing, whatever topical therapy or systemic therapy you're using for atopic dermatitis, patient and parent education is the most important thing because it's a chronic relapsing condition. So the take-home messages, regular use of moisturizer is the core of the management and it should be part of all stages of atopic dermatitis. Topical corticosteroids is the cornerstone of the anti-inflammatory therapy and should be used judiciously. Both overuse as well as steroid phobia should be discouraged. And calcineurin inhibitors topically, it can be used as a steroid sparing agent and can be used effectively. And lastly, the environmental control and parent education, both are extremely important. So thank you so much for your patient listening.
Thank you, sir. Thank you for your very lucid and very informative presentation and sensitizing us with the various topical management of the atopic dermatitis. Thank you so much, sir. Any questions regarding atopic dermatitis?
What is your view on minimal chain triglyceride oil application vis-a-vis the virgin coconut oil that you mentioned?
Yes, sir. That is what I told. As per our guidelines, oils per se are not advised. They are not recommended. But especially in the low socioeconomic group, when they are not able to purchase the costly moisturizers, we can try it, especially for the mild to moderate cases. But for long term, it is always better that you use a normal moisturizer containing all these things.
Further questions? If we don't have any questions, we'll move to the next session.
I request our chairpersons and Dr. Dhanesh Holwaikar sir and Dr. Vrushali Varad madam and our speaker Dr. Krishna Mohan sir to please come on the stage for a group photograph. Kiratkar sir to join, please.
ये आया क्या देखो
We request our chairpersons and the speakers to collect their mementos from the registration desk. This has been done to keep the time management tight. Thank you very much, everybody.
We'll proceed for the next session. It's a panel discussion. The moderator with us, Dr. Anand Pendurkar. Sir is a former president of Indian Academy of Allergy, and he's the founder vice president of the academy. He's a fellow of Indian Academy of Allergy and Indian College of Allergy, Asthma and Applied Immunology. He is also a member of European Academy of Allergy and Clinical Immunology and American College of Allergy, Asthma and Clinical Immunology. He is basically an ENT surgeon, and his specialty in asthma, allergy, and clinical immunology. He has published many textbooks, publications in journals, and chapters in textbooks. He is also a course director for the advanced course on diagnosis of allergy and immunotherapy. He has every year annual intensive training programs globally. Students are throughout the world in Nepal, UAE, Iraq, Nigeria, Bangladesh, Sri Lanka. He's also mentoring more than 290 certified allergy specialists. Sir, we welcome you.
Thank you. Thank you very much. I would like to thank and congratulate the organizers for this beautifully organized conference, and especially Dr. Khalatkar and my dear Dr. Rajkumar for giving me this wonderful opportunity. Where are my panelist doctors?
We would request the panelists, Dr. Palak Shah, Dr. Potluri Meghna, Dr. G.V. Basavaraj sir, Dr. Tarun Patni, and Dr. Suhas Kulkarni to join. The topic of panel discussion with us is very common and very relevant to everybody, which is allergic rhinitis. And it's a very catchy title given to it. It's not just a runny nose. So let's see how our moderator and panelists take us through the journey of this allergic rhinitis.
I have a great pleasure to introduce my colleagues on the panel. We will try to make it interesting, and I request them to be a little quicker so that we complete the whole thing as it is in the program. The lady first, Dr. Meghna Potluri, is an ENT surgeon and is a trained allergy specialist. She is in Bangalore and is a consultant in Apollo Hospital and Manipal Hospital there. Then we have Dr. Basavaraj, another senior dear colleague, a pediatrician from Bangalore. He's a consultant at several hospitals there, and we may see him as the president of the Pediatric Academy in 2023. I welcome him also. Then I have Dr. Suhas Kulkarni. He is an associate professor, pediatrics at D.Y. Patil Medical College, Kolhapur, with a fellowship in allergy and clinical immunology, and he's a PhD in pediatrics in PFT. That's quite interesting. Then we have Dr. Palak Shah, who is a pediatrician again and a certified allergy specialist from Vadodara. What is interesting is he is involved in a research project on airborne allergens with a special reference to pollen in the states of Gujarat and Madhya Pradesh. So with this very short introduction, I think we will commence now, and in the end, you may also participate. I would be very glad to have your participation as well. They have given me a very interesting and quite a catchy topic for this panel discussion: allergic rhinitis, not just a runny nose. We'll try to prove that it's not just a runny nose in the next few slides. May I now ask Dr. Meghna, what is the incidence of allergic rhinitis in this country?
Hello, very good morning to everybody. Absolute pleasure to share the stage with esteemed Dr. Anand sir and other panelists. So I start by saying that allergic rhinitis, as an ENT surgeon, practicing ENT and operating surgeon, is very common in my OPD practice. If I see my OPD, 20 to 30% of patients who come to my OPD have allergic rhinitis, but according to ISAC study, it's 42%. So when you put it on pen and paper, I think the percentage is much more.
Anybody wants to disagree with that? I think you are almost right. If you look at the global figures, this is what it is. And in India, in spite of not having properly conducted epidemiological studies, the entire burden of allergy, whether it is skin allergy or GIT or respiratory allergy, is about 25% of the total population, approximately. And respiratory allergies are the most common, and nose being the main door to the respiratory system, bears the brunt of allergic insult, and the number of cases we have of allergic rhinitis is very high. Setipane in United States, he reports that, he has collected data and he reports that 47% of the total population of North America suffers from either mild or moderate or severe allergic rhinitis. That is the load. If you discount the most common non-infectious diseases like diabetes and hypertension and cancer, which are the difficulties or the challenges of the seniors, allergy is by far, when you look at children and younger adults, it is the most common non-infectious disease, and it may not kill, but it affects the quality of life of the sufferer when the disease is persistent, and especially in rhinitis. So, like many of our colleagues, unfortunately, all over the world, believe that allergic rhinitis is okay. It's not a big deal, just a few sneezes and runny nose. One of our colleagues says, you clip your nose for just half a minute and see how nasty it is. Look at the burden. Dr. Basaraj, what is the burden of allergic rhinitis on the sufferer?
When we look at an allergic rhinitis in a pediatric age group, even though incidence may be less recognized and as it may not be as high as in adults. But the problem is the recognition is one of the things which is causing an issue. When you look at in a pediatric age group, what is the burden of this is basically school absenteeism is one of the major problem which is likely to affect. Sleep disturbances is another thing which is likely to affect. And the asthma is another thing. These are the things which is really bothers in school going children, which really in a matter of a worry. And previously we used to think about the moment we say allergic disorder, we used to think about only in industrialized countries, not in any developing countries like India. But it is not so, as the epidemiological things is changing over a period of time. This burden of a disease which is really causing a lot of issue.
Okay. Dr. Suhas, what do you think are the main symptoms of allergic rhinitis? Before that, I will just show you a few of the, look at the burden. These are globally collected data. Scading is a very senior colleague and a respected lady. Look how it affects the quality of life. So, allergic rhinitis is not just a runny nose. Dr. Suhas?
Yes.
What do you think are the main symptoms of allergic rhinitis?
So the main symptoms are sneezing, itching, running nose, that is rhinorrhea, and nasal block. These are the cardinal symptoms. Along with that, there are many other associated symptoms. There may be conjunctivitis may be associated. There may be itching over the nose or a throat clearing again and again. So these are additional symptoms which may be there. There's certain diseases like atopic dermatitis may be there along with that. And further, there is a whole lot of scenario is there, but I think we'll discuss that afterwards.
Okay. Dr. Palak, am I pronouncing your name correctly?
Yes, sir.
What are the signs, clinical manifestations and signs in allergic rhinitis?
Good morning, everyone. If we see about the signs of allergic rhinitis, they are basically classified, if we see from head to toe, then first they start with allergic shiners, Then there is a allergic salute also. Allergic mannerism is also there. Also, there is a long face syndrome. Also, they are characteristic with the transverse line on the nose. Also, if you see in a mouth, there is a cobblestone appearance. Also, there is a malocclusion of teeth also. Also, they have other use of accessory muscles. Wheezing is also there. Also, they have a in a nose, if we see, then there is a pale mucosa with a hypertrophy of an inferior turbinate also.
Okay. So you want to add?
So the examination of nasal cavity, I think, plays a very crucial role in diagnosis of allergy in pediatric as well as adult. And the pale and the boggy appearance of the turbinates and the appearance only, the turbinate hypertrophy, actually, as an ENT surgeon, I think we both can relate to it as soon as we put a nasal speculum inside and we know that this patient is allergic, even before we come to other things that need to be evaluated. So that is one thing I would want to mention to you, the examination of the nasal cavity with a speculum.
Yeah, either anterior rhinoscopy with the todicum or a nasal speculum. And if you have an endoscope, that will be a great thing to examine. You will get all the information, whether there are any other comorbidities, whether the patient is going into complications, all this information you will get. And if you pass a sterile kuchi or a cotton applicator under the inferior turbinate on the surface of the floor of the nasal cavity, and then you collect the secretion and also gently rub the mucous membrane and place it on a slide and observe under a microscope, you will see preponderance of eosinophils. Dr. Basuraj, what do you think is the significance of the late phase of allergic rhinitis?
Yeah, when you look at an allergic rhinitis, which is having an early phase and a late phase, these are the two components. Early phase, usually when the allergens comes in contact with the mucosal epithelium and all, dendritic cells is going to be stimulated, where there will be a mast cells which is activated, Th2 and IgE mediated response is the thing which is in early phase. Whereas in the late phase, as the 4 to 6 hours later, there the cytokine starts getting into the things like interleukin 4 or interleukin 13. So things will have a leukotriene mediated response is going to be there. That's the one thing which is likely to have a more morbidity and all. That's the time where which has an implication with the management of the things.
Yeah, the entire cascade of chymokines in the late phase are different. Histamine is a pleiotropic chymokine, but it can cause sneezing, pruritus, runny nose. But the late phase is the one that causes the obstruction. And for that, no matter what is the claim of any of the pharmaceutical company, no antihistamine H1 blocker is capable of relieving the symptoms of the late phase. Dr. Suhas, can you name one complication of AR?
Yeah, the common one which is seen and has been discussed in the morning is conjunctivitis, which is often seen. Along with that, almost 50 to 60% of the patients can have conjunctivitis. Rubbing of eyes is many times told by the parents or the child. And that is one of the common complications. In that, the increased tears are there, redness of the eyes there, then some conjunctival swelling may be there, or even lid swelling can occur in these cases. So these are the symptoms which are there in conjunctivitis.
Photophobia.
Photophobia,
A sensation of a foreign body in the eye. A child finds it very difficult to comply with. Dr. Palak, what is the next complication you think?
Sir, sinusitis. Because of sinusitis, usually the patient have a heaviness and there is a headache also. Also, there is a thick secretion coming from the nose. And because of the headache and headache and a pain, the child is not able to work properly or go to school properly. Also, there is abstinence and also there is a decrease in alertness also. And hence the child is not able to concentrate properly and there is an inability in the attention also.
Okay. Do you agree? You want to say anything?
So the repercussions of sinusitis and allergic rhinitis and uncommonly we don't talk about this complication as such, is eustachian tube catarrh that is seen a lot in children. They come with serous otitis media, and we always keep looking at the ear. But
That will
when
come.
we start digging in deeper,
We'll come to that.
yeah, so it leads to allergic.
Yeah. See, even before it becomes frankly established sinusitis, the ostia through which the secretions of this from the sinuses are transferred to the nasal chamber, because of the inflammation, they are blocked. That itself can cause a lot of difficulty in a suffering child. Like the eyes are our very near neighbors of the nose, the sinuses are also the very next neighbors. Now, Dr. Basuraj, you want to say anything about the polyps associated with allergic rhinitis?
Yeah, polyp is also one of the complications which is associated with an allergic rhinitis, especially which is likely to cause a lot of nasal obstruction and breathing difficulty. So this is one of the major thing which is really going to affect the quality of the life of any children, school absentees and all these things. And especially inferior turbinate is one thing where the hypertrophy is one of the common things.
Dr. Suhas, you want to add anything?
Yeah, nasal polyps can, there is a controversy about it, that whether allergic rhinitis itself cause it or there is an infection or some other reason. But the nasal polyps, they are more troublesome. There can be facial pain associated, sinusitis can be there. So it is very important to look at whether nasal polyps are present in the child with allergic rhinitis.
See, among the polyps, when the polyps are ethmoid polyps, especially, then you can actually straight away consider that they are the result of improperly treated allergic rhinitis. So the polyps, even if you do a polypectomy, the patient will need to continue to be on intranasal corticosteroid. That's very, very important, because the recurrence in polypectomy is very, the chances are very high. Dr. Palak, what do you think about is the next complication of allergic rhinitis when it is not properly, adequately treated?
Yes, it also causes involvement of the Eustachian tube and causes allergic otitis media, that is a glue ear, for which as a pediatrician, we usually require a help from a ENT surgeon to insert a proper grommet, so that with the help of ENT surgeon and us as an allergist and pediatrician can manage properly.
See, through that, when the cascading inflammation reaches the nasopharyngeal area, through the eustachian tubes, the inflammation can spread to the middle ear and cause this condition, especially in a child. This has to be recognized very early, because a child learns everything by imitation. The child intensely looks at the parents and how they speak, what are movements of the lips. That's how the child learns speech. When the speech is not developed, when the hearing is affected in speech frequency, the child's intellectual development may also be quite well affected. So it has to be treated well and very, very aggressively and adequately. And like he said, you need a collaboration or an association of an ENT surgeon. Dr. Meghna, what do you think is the next complication of the cascading inflammation?
Hyposmia and anosmia. So patient comes to the OPD with a decreased sense of smell, sometimes perversion of smell also, because of long-term effect of allergic rhinitis. That's how they present. And then when we are diagnosing it, if we do an allergic skin prick test, that's always better to find out if allergy is the cause for this or any other causes for this hyposmia or anosmia is there.
See, there is an umbrella of innumerable nerve endings of the olfactory nerve in the superior area of the nose, when allergic rhinitis, persistent allergic rhinitis is not properly treated, this is one of the causes for this hyposmia or anosmia, which can affect the growth of the child because the olfaction and appetite of a child for anybody is also they're closely related. So you will see that the child is not properly grown, or there is a retardation of growth also. Dr. Basavaraj, what do you think would be the next?
Yeah, one of the another complication when you look at an allergic rhinitis is a change of the voice, and the patient can have laryngitis. It is one of the other complication we come across in the pediatric patients. And this is the one thing when there is a change in the voice, that's the time where we need to, sometimes it could be triggered by some of the other factors too. So we need to be looked in very carefully about an allergic laryngitis and pharyngitis. These are the other things to become.
So there will be a loss of timbre of the voice, strength of the voice. There can be hoarseness. And then there can even be a nodule, singer's nodule. Even our greatest, one of the greatest singers, Lata Mangeshkar also had the singer's nodule once. Then before it affects the larynx, it can even cause some symptoms in the pharynx. A sore feeling, difficulty to clear. So because the secretions in the nose, the consistency has changed. Then one feels difficulty to, otherwise one naturally swallows and it goes into the stomach. So what is the next complication you think of the cascading inflammation, Dr. Suhas?
Yeah, sir, cough variant asthma is one of the very common complication which we all come across. And there is a dry hacking cough, then the child usually does not show other symptoms, but has cough intermittently at night or in between. And the cough is treated, but nobody looks after the allergic rhinitis. So we have to remember that this cough variant asthma can be there in the case of allergic rhinitis while treating these patients.
So even before it reaches the lower airways, when it is affecting the trachea, then there can be this hacking cough. The only advantage for such a person is at night when he is coughing, the thieves do not dare to enter the house. Dr. Palak, what do you think is the next complication?
Sleep disorders. Usually a child with allergic rhinitis will also have a sleep disorder. Because of persistent symptoms, the child is not able to sleep properly. And because of a poor sleep quality, there is affected his school and also his routine work also, which further leads to further anger and irritation and followed by the agitation also. So we need to take a proper care of a sleep also.
Okay. Do you think asthma is one of the complications of
Yes.
allergic rhinitis,
Yes,
Dr.
yes.
Meghna?
Yes, sir. Absolutely. So I think pediatricians and pulmonologists see this very frequently in practice, saying a child or the adult has come with chest congestion. And when they evaluate it further, it is because of untreated allergic rhinitis, which has progressed to allergic bronchitis and bronchial asthma.
Okay. So I would like to underscore one point. About 20 or 30 years ago itself, one of our senior colleagues in Amsterdam, Dr. Weitske Fokkens, and her team, what they did was, in those cases of allergic rhinitis, with no symptoms whatsoever of the lower airways, pulmonary function was normal. They just did a very simple thing. They took some biopsy from the lower airways and they found that there was hyper-responsiveness in the lower airways also in cases of allergic rhinitis, persistent rhinitis. So showing that the allergic march, right at that time, they were mentioning about allergic march. And then they could even consider that allergic rhinitis, when it is persistent, it could be called as latent asthma also, some of them they said. Dr. Basavaraj, what do you think is the next complication it can lead to?
Yeah, it can lead to one of the things is an asthma is one of the COP variant or bronchial asthma is one of the complications we always need to be looked in. Also, and also it is likely to affect the overall quality of the life also. Sir.
So asthma can actually also get led to COPD also. So allergic rhinitis is not just a runny nose. What is the most common allergen in your opinion, Dr. Suhas?
Sir, dust mite is the most common allergen. Like we do DP and DF or test, and as in the morning, Dr. Holwekar said, this blomia is also there. So this is the commonest one. Yeah.
See, in your practice, it's very common for many of your patients. If you're pediatricians, you're the mother of the child. It's the mother is the main anchor, not the father. She tells you that when my child is exposed to house dust, his problems appear or his symptoms get triggered or exacerbated. House dust is a complex substance. It's a hodgepodge of substances, both organic and inorganic substances. There are several ingredients in the house dust which can cause allergy, like cockroach allergen and other ant and other insects, sometimes even pollen and fungi. But it is this tiny little insect called as house dust mite, which is the most predominant allergenic component of house dust. And now we know that there are three main species: Dermatophagoides terranicinus, Farinae, and Blumia tropicalis. These are the three main clinically significant or important allergens. In tropical countries and subtropical areas like India, Australia, New Zealand, and some of the West Asian countries, Blumia tropicalis is the most major species of house dust mites. And these mites, under conditions like about 20 to 30 degrees centigrade temperature and about 60 to 70% humidity, they simply thrive. Our own skin scales are the best culture medium for the house dust mites. They thrive either themselves or their dead or alive parts or the tiny little fecal pellets. They are the most virulent allergens. When we did some studies in the early 80s in Bangalore, we took some scrapings from the mattresses of some asthmatic patients. We found several thousands of such mites per gram of house dust. Look at this. Under an electron microscope, when you observe and when it is magnified about more than 3,000 times, this is how it appears. I'll show you a video clip. These are the live mites. They live right in our mattresses. They forage. They multiply and release allergens. Not only for airways, even for atopic dermatitis, house dust mites are one of the common causes. So, allergic rhinitis, my friends, is not simply a runny nose. Okay. Who is the next? You want to make a comment, Dr. Palak? What is the next common allergen?
The next common allergen is basically a pollen. And this pollen are basically, it depends on which part of India it is. And it usually they are basically because they are seasonal. allergic rhinitis and a perennial allergic rhinitis. If it is a continuous, chances of getting a continuous pollen in that area is very difficult. Like I work in Gujarat. In Gujarat also we get only in specific season only we get pollens.
Okay. Anybody wants to agree or disagree?
Yeah, pollen is one of the common thing. What we need to remember is pollen, which is likely to move many kilometers in a air. So what is very important in this is we need to look at the in particular, which particular season it is going to be there. That's the time where we need to avoid those things.
Okay. Let me tell you. Pollen released in a particular place. These are anemophilous or airborne pollen, pollinated through air. These are very tiny, so small, and they are non-sticky. Because of the eddies in the wind current, they can travel quite high, and they can even be traveling up to 100 miles. And when there is a cloud burst, like it has happened recently here, the pollen get fragmented. As it is, they are very tiny. They find it is very easy for them to gain access into the airways. And when there is a cloud burst, they become fragmented and they enter the airways, even the lower airways, very easily. What is depicted here is this. Okay, what do you see around the 10 o'clock position? What you see around 10 o'clock position is the yellow structure that is an anther, a sac-like structure in a flower that stores the pollen grains. There are some plants which disperse their pollen grains by means of water, hydrophilus, some by means of insects, entomophilus, some by means of wind. These are the ones that are very important for us to know. These are the ones that cause respiratory allergy commonly. These are anemophilous plants. Pollen is the male gamete of any plant. And what you see here is the released pollen grains, and then they become airborne and reach the nasal cavity of this unfortunate sufferer, causing an insult on the nasal mucosa and then causing the classical symptoms of allergic rhinitis. When you examine them under an electron microscope, that's how they appear when they are magnified about 3,000 times. We will very quickly show some very common plants which are the source of pollen. This is common grass, garike, Bermuda grass. For Ganesha, you often know that is it. And there is a high level of cross-reactivity between different grasses. This is another grass which is more common, I think, even in Vidarbha area, but also in near Mumbai and Pune. This is Ishimum. This is a weed, but it's called as grass, Congress grass. I think because the racemes look like the caps worn by the Congress politicians, or during 1972, the government of India inadvertently bought the wheat from South American states, and this came as a gift to us. This is one of the common weeds, and there are several of that of different species, but from the same family, there is a cross reactivity. This is another weed, Utrani. This is used for making some puja items. This is Amaranthus spinosus. This is another weed which grows like a menace. It is does not cause atopic dermatitis, but it's one of the common allergens for respiratory allergy. Look at this tree. This picture I took, I think, somewhere between Chidambaram and Pondicherry near the backwaters. This is Prosopis juliflora. universally present unless, for example, it is present in Jammu, but not in Srinagar, not in Leh, like that. And look at the regime. Look at the pollen are very easily released. And one of the most common causes of pollen, airborne allergy, and then respiratory allergy, both rhinitis and conjunctivitis and asthma. This is another tree. Unfortunately, it's very popular with the authorities because of the beautiful yellow racemes and green foliage. It is planted as an avenue tree. This is from the administrative office, Crawford Hall in Mysore University in Mysore. Look at the racemes and then look at the way the plant modifies the flower, and it is right now it is in bloom. It is the time until maybe end of September, and they are very heavily pollinating, and the way it modifies the flower, the anthers release the pollen grains and they become airborne very easily. So my friends, allergic rhinitis is not just a runny nose. It can cause a lot of difficulties, and the causation is quite complex. So then there are, who is the next one? Yeah. What are the other triggers?
There are certain known allergic triggers also, which can aggregate, like any infection, if there is any hormonal imbalance also, like dust, smoke, fumes and smells also, if there is a tension or stress, depression, and some intolerant food and additives can also cause, and preservatives and colors used in it.
Okay. Dr. Meghna, you want to say anything or you agree?
I agree, sir. The factors given are quite on point.
Quite a few young women tell me that they're allergic to their mother-in-law.
That is unavoidable.
Mother-in-law does not cause allergy. Some of the women, no, they're quite true, because this lady gets married and in our system, suddenly, overnight, she has to go to a different place and live there as if it's her place. And then she has to comply with everybody's orders. And mother-in-law many times causes an emotional difficulty. And if she is a patient of allergic rhinitis and the disease is persistent, she can naturally trigger the symptoms. Similarly, it can be otherwise also. Daughter-in-law also can cause. Peers, teacher, students, your colleagues at workplace. All these people can cause a trigger. So the triggers are not the allergens. Mind you, there is a common feeling that many times people tell you that, sir, the dust on the road, it causes allergy. No, it does not contain any allergen. It contains only soil and other things. Only the house dust, not paper dust, not cotton dust. You see so many people getting this in vitro test done, and you look at the results, there is a positive response given or a negative response given for nylon, paper, cotton, husband, tobacco, so many things. So don't believe that. It's not the right thing to do. All these things, it's a racket. They should not be used. And it's unfortunate that many of us get sucked into because they give, okay, we collect 12,000, you take 2,000, he takes 2,000. This is unfortunate. That's not practice of medicine. So this is also one of the major triggers. Dr. Basaraj, you want to comment on this?
Yeah, nowadays with the industrialization is the things which is happening, and a lot of traffic is one of the things, especially dry air and cold air, and this is a smoke. These are some of the things which is really causing a more allergic disorder. This is where our role really lies in controlling this.
Dr. Suhas, you want to comment, I think?
Yeah, sir. Dr. Parmeshwar is here. So diesel exhaust particles, they combine with these pollens and they become more allergenic, or some other particles. Also, then the suspended particulate matter, which is there, you can get all this pollution every day we can actually watch them. And wherever pollution is more, the allergic disease, they are increasing.
So in urban and semi-urban areas in India, we're talking only about India now. The air pollution is one of the major triggers. It does not cause allergy by itself, but there is a compromised situation in the ambient air quality, and that is the one. So the noxious substances that are released, for example, gases related to carbon, both dioxide and unfortunately carbon monoxide. A very interesting study was conducted by Indian Institute of Science, and one guy carried a simple machine in an auto rickshaw from Malleshwaram to another part, Jayanagar, nautical distance could be about 8 to 9 kilometers, that's all. At every traffic signal, when the vehicles would be idling, he found that the carbon monoxide level simply shot up. Carbon monoxide has a very high affinity to combine with hemoglobin. It forms a very stable compound, carboxymeth hemoglobin. Oxygen is nowhere to compare with. Even if you are not atopic, even if you don't have any respiratory symptoms, you go on a scooter or a motorbike, you are exposed to this. By the time you reach your office, after traveling 5 to 10 kilometers, your energy levels are already low because it affects the mucociliary function. We are endowed with this gift of nature, Mother Nature. We have this mucociliary function. In a normal person, if you instill a dye at the anterior nasal chamber, and after 15 minutes, if you examine the oropharynx, you will see that this dye is already there because of the nasociliary function. It is a gift, and this will be affected. There is a damage, there is a leakage. That's what happens. So allergic rhinitis, so it has both the susceptibility of the individual and then the causation by the allergens and triggers. So it's not just a runny nose. Dr. Suhas, would you like to say anything about the antihistamines?
Sir, the antihistamines, especially second generation antihistamines, are very useful in allergic rhinitis. And in case of mild intermittent allergic rhinitis, they can be prescribed. And first generation antihistamines should not be prescribed because they affect the sleep quality. And second generation antihistamines can be given for a long time also. So they are very useful. And this antihistamines, which were actually discovered, invented, and that's why a Nobel Prize was given to Dr. Bove.
So the antihistamines, H1 blockers, have a definite role in the management of allergic rhinitis, especially when the disease is mild. We don't need anything else. And as a niche in persistent rhinitis, when the patient is on intranasal steroids, in some patients you need as an add-on therapy. You try antihistamine, then you think of Montelukast, not straight away. This great man, 38 years of constant research, Daniel Bove, he discovered the first molecule, thymoxymethylene, and all the molecules that we have today, including the latest belastin, they can be traced to that. So please stick to the standard prescribed dose. So we were talking about the late phase. Once the disease is persistent, once there is the nasal obstruction, can we get just maybe 2 minutes or 3 minutes? Can we? We'll complete it. Okay? Rajkumar, can we get another 2-3 minutes? Yeah, okay, thank you. So thymoxy, okay, we come to the mediators. So like I said, histamine is the pleiotropic mediator. Dr. Palak, you want to say what happens in the late phase and what is the correct treatment?
In case of a late phase, actually there is a recruitment of all the cells. There's the basophils also, eosinophils also, and neutrophils also. And because of that, there is a secretion of the multiple leukotrienes and other substances, which causes basically a nasal congestion known as a nose block, which further causes a bronchial hyperresponsiveness. So in this case, that is a late phase response. Only the intranasal steroid has a good role rather than antihistamine.
Okay. There is a belief that montelukast can address all the symptoms of persistent allergic rhinitis. Montelukast is a modifier of the leukotriene. Leukotrienes are only one of the components of the entire cascade. So it is the intranasal steroids that is the mainstay of management of persistent allergic rhinitis. Montelukast can be used as a niche between the mild and persistent rhinitis. Maybe there you can use montelukast, but you be careful when you choose montelukast. I think it is one of the most commonly used, abused, and misused molecules in this country, especially in combination with a H1 blocker like fexofenadine and levocetirizine. Then there are the combination of antihistamine like azilastin with fluticasone. There also, I would say that in some patients, there can be medication-induced rhinitis because of this short-acting antihistamine. So it may be a good idea to use it for short duration and then take out one of the azilastin, which is the antihistamine, maintain the patient only on intranasal steroid. That would be the classical best and safest way of managing. So this is what the steroids do. They can address all the cascade of inflammation. And if you have to, Dr. Meghana, how do you make a specific diagnosis of allergic rhinitis?
We need to go ahead for the skin prick test, sir. Depending on the relevant allergens in the area also, that is very important. Like if you are in Delhi and in Bangalore, what you are looking for is also sometimes different. So you will have to first do a study about the relevant allergens in your area and plan your panel accordingly.
Yeah, diagnosis of allergic rhinitis basically lies within a good clinical history. That's the most important thing, and good physical examination. Of course, skin prick test is one thing which really adds on to it. Most of the common mistake as a pediatrician, what we do is like trying to look at it in IgE level. IgE level has a limited role in the diagnosis of an allergic rhinitis. It is a clinical history and examination. Of course, skin prick test is the thing which really.
Yes. Like you said, total IgE estimation is not relevant to countries like India and other Asian countries and Africa because we are helminthic population. Even roundworms can increase the total IgE. It's not a diagnostic tool for us. And the specific IgE, unfortunately, only the pharmacia product is good, but it's not made for many of our allergens. And then there are several laboratories which are running a racket. They're doing unethical practices. It is the gold standard is to do skin prick test, not only in India, in Europe, North America, Australia, New Zealand, anyway. Then when sometimes you need to do a specific IgE estimation if you have the facility. So skin prick tests done properly are quite an excellent tool to make a specific diagnosis of allergy. That's how you do. You place a small bolus of the allergen, which is about 1:10 dilution glycerinated, and you make a micro prick through the drop with a 23 gauge needle, or use a blood lancet and then try to raise the uppermost layer of the skin so that the allergen enters the most uppermost layer, and then within 15 minutes, because it is IgE mediated, immediate type of hyperresponsiveness. So within 15 to 20 minutes, you do the reading. That is quite, look, that is the area, stratum corneum epithelium. That's where you actually make the prick. You should not make the prick deeper than this. So this is what is a good positive response. That's more than 3+. So you use a control, negative control, which is buffer saline. You use a positive control, which is histamine, to measure the basic response of the patient. And then you compare it with the response of the allergen. You make a specific diagnosis. Like he said, it has to be always correlated with clinical features. So, Dr. Suhas, would you like to say anything about cure? Do you think allergic rhinitis can be cured with, especially with allergen immunotherapy?
Yes, sir. The allergen immunotherapy is very good for allergic rhinitis. In cases of allergic rhinitis, if you can properly diagnose the allergen, especially it is very useful in dust mite allergy. And immunotherapy gives excellent results. And patient did not take, the only thing is with allergen immunotherapy, it has to be taken for at least 2-3 years continuously. It should not be stopped, and one has to go slowly, and then for first few months, patient may not get the results, but continue with the allergen immunotherapy, it can almost cure the patient.
Yeah. You want to say something?
The only disease modifying treatment available for allergic rhinitis is known to be immunotherapy, allergen specific immunotherapy.
Allergen immunotherapy is the only tool, curative tool available. Of course, if you are able to isolate the patient from allergens and triggers completely, then you may achieve the same thing. If it is possible, in some very few cases where the allergen is a particular one, like for example, one is allergic to the cat or dog, allergen as an indoor allergen or a food item, then it is possible. Not always, even if it is. It's quite easy said than done. So if do not attempt immunotherapy in those cases of mild rhinitis or mild asthma, then even if you achieve 80%, 90% benefit, it is not perceivable. When the disease is persistent, when the patient says, I have this horrible disease called as allergic rhinitis, it causes a lot of difficulty for me, both at school, at workplace, and in social activities. Then you insist in institute allergen immunotherapy. In the beginning, you need both medical management and immunotherapy, both. As the patient progresses, you can start doing the medication sparing benefit to the patient. Choose the correct allergens, do the allergen testing properly, and institute immunotherapy, and you have to reach quite high concentrations, and the tenure is in sublingual immunotherapy, which is the best approach now, is tenure for complete cure for life, means you have to take it for 5 years. Okay. So allergy is a systemic disease. It's an inflammatory condition. If we do not treat it, it cascades. It causes complications. It causes comorbidities. Unattended cascading inflammation is the main problem.
Sir.
So just last one. So that's why are we happy? Do we agree that allergic rhinitis is not just a runny condition?
Absolutely.
Okay, last 2 slides. These are health-friendly trees. All plants do not cause allergy, and this city needs such a tree like Avalandia, Cabibia avalandia, very beautiful tree. Thank you very much. His grace be on us. Thank you. Thank you for a wonderful, for being a wonderful audience. Thank you, my panelists. And if the time permits, if there are any questions, I think they may be happy to take.
Thank you very much, sir. Actually, few of our speakers are waiting online for the next session. So with the interest of time, we would request all to join together for a group photograph. Dr. Kiratkar sir and Katwal sir to please join for a group photograph on stage.
Thank you for giving us those extra 2 minutes.
We request our chairpersons, our speakers, panelists, and moderators to collect their mementos and certificates from the registration desk. If there are any questions, the delegates can ask them in person at the end of the session or during the lunchtime or during the break time. Thank you very much, sir. Now we shift our attention from allergic rhinitis to some important other topics and aspects in allergy and immunotherapy. For the next session, I would request Dr. Patil sir, Aji Patil sir, and Dr. Kush Junjunwala sir to come up on the dais and take their seat as chairperson. I would request our technical team to please put on Dr. Mahesh Babu sir for next session on the screen, please. Over to our chairpersons, Dr. Patil sir and Junjunwala sir.
Thank you, Dr. Nikhil. Good morning. First of all, I would like to thank the organizing committee member, Dr. Rajkumar Kiratkar, Dr. Pritesh, Dr. Vasant Khadkar, and all the office bearer of this conference. As all of you know, there are some problems in sleep apnea. How to treat and how to diagnose the sleep apnea. In adult, it causes daytime sleepiness. But in children, there are n number of problems if you don't diagnose in the proper way. They may cause some memory changes, behavioral changes, cognitive problems, and growth retardation. So today we are having a well-known speaker, Dr. Mahesh Babu. So I welcome you, sir.
Thank you. Thank you so much, Chairperson. Thank you for, I would like to thank the organizers at the beginning to have invited me for this wonderful conference. I'm sorry I can't be on site, but I have to share my talk on the Zoom. I hope all of you are able to hear me. Can you all hear me?
Yeah, sir.
Okay, great. So I will try and keep this talk a little bit interactive. If let me see if it works. I've been asked to speak on diagnostic approaches in obstructive sleep apnea, and therefore I'm going to limit my talk over the next 20 to 30 minutes just to this particular topic, not talk about management or the introduction to it. Now, as I said, I would like to keep this talk as interactive as possible. And therefore, what I'm going to do is I'm going to ask you all on your mobile phones to type in pollev.com/Mahesh. If you type this on your browser, you will get to a website which is an anonymous poll. If you prefer, instead of using the website, if you prefer to use the QR code, you can use your mobile phones to just quickly scan this mobile QR code. You should be able to get to the same website as well. So either you can use the QR code or you can type in pollev.com/Mahesh. So I'll wait for a few minutes for you all to log in. I can see a few of you are logging in already. So it is again POLLEV, poll everywhere, pollev.com/Mahesh. For those of you who want to get a QR code, I'll put up the QR code again. This will be useful since we can have an interactive talk over the next 20 minutes, because my answers and my discussion will depend exactly on what you guys want and think. Okay, so this is, I'm surprised about 9% of you are sleeping more than 8 hours. Really, that is not very common. And I'm happy to see that COVID has changed. So maybe that number is dropping down to 5% already, but yeah. Okay, so now that there is a reasonable number of you who are able to interact, let me go ahead with the talk. The way I have scheduled this talk is basically I have given you some case scenarios. And once the case scenarios are done, then we will take you through the process of diagnostics in obstructive sleep apnea. So case scenario number 1 is a 8-year-old child who was brought to you with a history of loud snoring in the past 6 months. Mother says she does have frequent snoring, and mostly when she is very, very tired. She's well otherwise, no history of any witnessed apneas, no history of any hyperactivity, no history of excessive sleepiness during daytime. Examination is completely normal. No adenotonsillar hypertrophy was seen in this kid, right? So I'll give you 10 seconds more to look at it, because the question then comes is, what would your management be for this child? Given this child, examination normal, 80-year-old in your clinic, what would you do? Would you say, I would like to just reassure and send them home and follow up? Would you say, I would like to investigate this kid for the presence of obstructive sleep apnea? Or would you say, I would like to refer this kid to ENT doctors for an adenoid tonsillectomy? Okay, still about 75 to 80% of you want to investigate for presence of OSA, and about 25 to 30% of you would like to just reassure and follow up. I'm not going to tell you the answers now. I will tell you in a short while. Let us see another scenario. This scenario is a child, a 10-year-old child who presents to the clinic with a history of loud snoring for almost 4 days in a week for the past 6 months. His mother says that she has seen some witnessed apneas. Harish is also known to be hyperactive at school. His teachers are worried about his learning difficulties and grades. And on examination, he almost has kissing tonsils. Otherwise, the rest of the physical examination is completely normal. I'll give you another 5 seconds to read this.
Tonsils.
Okay. How will you manage this child? Would you say reassure and monitor this kid? Would you say, I would like to investigate him for the presence of obstructive sleep apnea? Would you say refer to ENT for adenoid tonsillectomy? Again, for those of you who haven't got into the poll so far, it is pollev.com/Mahesh, or you can go to this QR code, which I am flashing. You can scan the QR code and you should be able to get onto the polls immediately. This is totally anonymous, as you are seeing. Your name will not come up and nobody else will know what you answered. So that's fine. So here things have changed a little bit, isn't it? So a majority of you would say, hey, you know what? I love my ENT surgeon next to my door. I would like to refer it to him. And some of you say, you know what? I would like to investigate. I think it's not enough still, the history. All right. Okay. So that's the group. I'll move on. Case number 3 is different. A 3-year-old child with trisomy 21 who presents to the clinic with regular snoring. No witnessed apneas or daytime symptoms. She is known to have a small ASD, atrial septal defect. No adenotonsillar hypertrophy seen. Her systolic blood pressure is slightly high than the 95th centile for age. Rest of the systemic examinations were completely normal. Okay, what would you do for this kid? Would you reassure and monitor? Would you investigate? Or would you refer to ENT for surgery? Interesting. All right. So here about 50-60% of you would like to investigate and 40% of you would like to reassure and monitor. Okay, here I want to tell you a couple of things. Your patient number one was a straightforward 8-year-old girl with physically completely normal who had snoring mostly when she was tired. Otherwise, she was completely okay. These kind of scenarios, you don't really need to jump into investigating or treating. So those of you who answered for that kid, reassure and monitor over time is probably right. I will tell you some of the symptoms later on, but that's the answer for that one. The second one was very straightforward, typical 10-year-old with obstructive sleep apnea symptoms, and he had quite significant tonsils and adenoids on his clinical examination. Sometimes academicians might do investigations to rule out or to rule in and look at severity of obstructive sleep apnea. It's not wrong. But for the majority, I would say if you refer straight away to an ENT surgeon, that probably is the most appropriate for patient number 2. Of course, we now know adenoid tonsillectomy is not a complete answer for obstructive sleep apnea, and therefore you might want to monitor the child after the surgery. Child number 3, which is our child with trisomy 21, you should realize that children with trisomy 21 or Down syndrome are very, very prone for obstructive sleep apnea. They have many factors like hypotonia, enlarged tongue, enlarged adenoid tissues, obesity. There are many factors because of which they are very, very prone for obstructive sleep apnea. And therefore, the guideline as of today is even if they don't have symptoms, they all need to have some evaluation for obstructive sleep apnea, preferably a polysomnogram before the age of 5 years. Especially in this kid who has snoring, you definitely need to have an investigation. And therefore, those of you who answered investigate for the presence of OSA are correct in this particular scenario. Okay, so that's the brief things that I wanted to talk to you about, the clinical scenarios. I've given you the full spectrum, when to operate, when to investigate, when not to investigate, etc. So what are the different diagnostic tests which are, I was hearing the previous session on allergic rhinitis and on treatment. I think Dr. Baswaraj said very clearly, first of all, you need to go back to history and then history and then history and then examination. And similar things work out for obstructive sleep apnea. History and questionnaires is probably going to be the first thing that we need to do. So take a detailed history. So when we talk about history, what are we talking about in obstructive sleep apnea? This is a set of questionnaire called the BEARS questionnaire, BEARS. This is not specific to obstructive sleep apnea. This is specific to sleep in general. So you want to ask bedtime problems. Are the children afraid to go to bed? Are the children afraid of darkness? Are they resistant to go to bed, or they are not going to bed at the same time every day? All of those. E is excessive daytime sleepiness. I think, as the chairperson said, excessive daytime sleepiness is most often seen in adults with obstructive sleep apnea. In children with obstructive sleep apnea, they have more daytime hyperactivity. Of course, the one major exception to this are children with obesity. So adolescents with obesity present with excessive daytime sleepiness. A is awakenings at night. You want to see how many times they wake up in the night. And R is the regularity, what time they go to bed during weekdays and weekends. Is it regular, abnormal, etc.? And of course, you ask for snoring. So this is in general about sleep. For obstructive sleep apnea, you ask two main categories of questions. So you ask for nighttime symptoms, and then you ask for daytime symptoms. In the nighttime symptoms, you ask for snoring. And in snoring, the key question to ask is the regularity of snoring. Is the child snoring every single day, or only when the child is very, very tired? If the child is very tired, like in our case number 1, it's got very less significance. Children who snore for more than 4 days in a week consistently are called habitual snorers, and those are real problematic snorers. So those would be taken care of, right? You also need to be asking for witnessed apneas. I normally your parents don't understand when you say witnessed apnea. So I demonstrate it to them. So I show them two types of snoring. I'm going to show it to you now. The first snoring would be something like that would be normal snoring. A child with witnessed apnea would be doing something like this. That's a typical child with witnessed apneas. Once you show this, then the mother will jump up and say, yes, I've seen this. Or she will say, I have not seen my child doing this. I have seen my husband doing this. So typically that's what the answers that would get. Labored breathing, where you ask whether the child has difficulty breathing, labored breathing, whether the child is restless in sleep. The child has enuresis, nocturnal enuresis. They have a higher incidence of enuresis in children with obstructive sleep apnea. Sometimes the children sleep with their neck very hyperextended, or they have increased incidence of sleepwalking, sleep talking, etc., which are called parasomnias. So daytime, they might have difficulty waking up in the morning. And after they wake up, they might have morning headaches, which is a typical symptom. They can have dry mouth because they open mouth breathe a lot, and therefore they all get up with a dry mouth. They can have excessive daytime sleepiness. I told you children with obesity particularly do this. And children usually have hyperreactivity and poor attention span. And as the chairperson said, they have a lot of cognitive abnormalities, so poor school performance. A child who was doing well in school, if the performance starts dropping, the marks start dropping, then you know there's something wrong. They can also have poor growth or failure to thrive in significant obstructive sleep apnea. So when there are so much of symptoms, what people came up with is they came up with something called the questionnaire sets, where you can actually literally have a set of questions. You can give it to the parents, they can check it off. And once you check it off, there is a scoring system and you can score whether the child is abnormal or not. It would have been really easy if it was working. Unfortunately, the sensitivity and specificity of questionnaires in obstructive sleep apnea is not very good. And therefore, at best, questionnaires are good screening tools, and they are not really the best thing to happen. And therefore, you should use your questions and history, but that is only to get a guide if something else is happening in this child. That is the limitation of history. The next two things, the audio recording and video recording. See, nowadays, everybody has a smartphone, and sometimes parents bring the recording of their child in the night, when they are snoring, or when they either an audio or a video recording. This is a very, very useful thing for you to see what is happening. But sometimes it is only the tip of the iceberg. It really doesn't tell you the full story that is happening for this kid. And therefore, the sensitivity, specificity of this is still not very good. Of course, more and more studies are being done with the improvement in technology today. And hopefully in the near future, we will see better recording facilities. For example, parents record events when they are awake, right? So by the time 10:30, 11 or 12 o'clock, when the parents go to bed, the maximum amount of obstructive sleep apnea happens in the middle of the night, around 2 a.m. to 5 a.m., when the REM sleep is more. And therefore, audio and video recording will miss out on the most crucial parts. You would have all heard about nocturnal oximetry or saturation monitoring study overnight. And that is something which is very useful in obstructive sleep apnea. So let me talk a couple of words about that. So obstructive sleep apnea is not a single entity, as if it is a single entity. I have been speaking so far, but actually it's a spectrum. On one end of the spectrum, you have normal children, and the other end of the spectrum is obstructive sleep apnea. So in children with obstructive sleep apnea, you have hypoxia, you have hypercarbia maybe, and you have difficulty in breathing and frequent arousals, and their EEG shows frequent arousals. But there are many conditions in between where children still have abnormality in their EEG, and which affects their cognition, etc., but they do not have hypoxia. And therefore, one thing that you have to remember is if you are measuring oxygen to see whether there is obstructive sleep apnea or not, you are only going to diagnose children who are in the extreme category to see if they are OSA or not. And therefore, you need to be aware of that. So how many of you in the audience use overnight pulse oximetry for looking at intermittent hypoxia in obstructive sleep apnea? So how many of you have used pulse oximetry for obstructive sleep apnea in the audience? Good. I'm so glad you're so honest. About 10 to 20% of you use, about 80% of you don't use it very much. Okay, I'm going to move on. And for those 10 to 15% of children, students or doctors who are using it, what do you think is the averaging time of your pulse oximeter? Answer is, I don't know. Answer is 2 to 3 seconds. Answer is 15 to 20 seconds. Don't guess. If you know, you tell me. If you don't know, just say, I don't know. Okay. So when I say averaging time, see, all of us, when you would have all seen pulse oximeters in the hospital anyway. So when you put on a saturation monitor, the machine goes beep, 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 beep for every single heart rate, right? And you will see the saturation numbers keeping going up and down, up and down. And it almost leads us to believe that the saturation for every single heart rate is being picked up. That is a false thing. What the machine actually does is it records the saturation over the last 15 to 20 seconds, and then it gives you a single number, which is the average saturation for the last 15 to 20 seconds. And that is a typical ICU monitor. Okay. But in obstructive sleep apnea, you do not have sustained hypoxia. You can have somebody who stops breathing for a few seconds, then you can have hypoxia for just a couple of seconds, 2 seconds, 3 seconds, and then it comes back up to baseline. So if you take an average of 15 seconds, you will miss out on all the intermittent small hypoxia. And therefore, for looking at obstructive sleep apnea, if you're using pulse oximeter in the night, you really have to use something with a very, very low averaging time, like 2 to 3 seconds. And that is very important for pulse oximeter. So what are the pros and cons of pulse oximeters? It is very easy to perform. It's got automatic analysis. I will show you some reports you can get. It's very inexpensive. It's accepted well by parents. And if you show significant hypoxia in obstructive sleep apnea, then you basically, with a history and significant hypoxia, you don't need to do anything. You can just send the child for management. However, if you have a normal pulse oximeter study, I told you pulse oximeter only diagnoses the extreme cases. And therefore, if you have a normal, no hypoxia, that doesn't mean the child doesn't have problem. The child can still have a problem, and therefore you need to do other tests as well. The other key thing is it doesn't differentiate between obstructive and central apnea, and it only tells you there is hypoxia. Okay. We spoke about. This is a typical report that we get in our hospital. It tells you how much time the recording was done, what was the highest saturation, what was the lowest saturation, how much time the child spent above 90% saturation, how much time the child spent less than 90% saturation. So there's a lot of data which you can record, and it is. So what we do is overnight, we put it on the child. Sometimes we give them home. And when next day, when they return the machine, we just plug it into the computer, and the computer generates this report for us. Based on this report, there are excellent criteria called the McGill's criteria, which tells you whether the study is positive or not for hypoxia. Not only that, using the McGill's criteria, people have come up with a scoring pattern where you can literally go and say whether it is mild, moderate, or severe apnea. So the last thing And the thing that I think most of you want to hear about is polysomnography. I kept it to the minimum because pulse oximeter, the polysomnography is not very, very commonly available. And that's what I would like to know from you all. How many of you have access to sleep lab in pulse or polysomnography? A, I do not have access. B, I refer my patients to adult sleep lab. And C, I refer my patients to an pediatric sleep lab. I know the reality in Nagpur, so my good friends are there who keep telling me about it. Okay, so about 75% say I don't have access to sleep lab, and 21% say an adult sleep lab who is able to do it for my child. The first one, I know it is very, very problematic all over the world. And the only caveat I would say is for those of you who are sending to an adult sleep lab, make sure they are using pediatric criteria for pediatric children. The probes are slightly different. The sensitivity is different. The scoring patterns are different. So if you're using an adult sleep lab, make sure that you give you proper pediatric studies. So what are the different probes that we use in obstructive sleep apnea? You use a lot of probes over the EEG, extraoculogram to look at eye and muzzle. That is for the staging sleep. We look at airflow to look at breathing patterns. We look at respiratory effort by putting a belt around their chest and abdomen to see if they are making an effort. Then we look at oxygen, carbon dioxide, and also record snoring during the sleep. And this is how a typical polysomnogram will look. These squiggly lines are all the EEG. This is the pattern for airflow. This is the abdomen and thoracic movement. So some of the common patterns you need to know is central apnea, where the central respiratory center fails to initiate breathing. In that case, the chest is also not moving because there is no inspiration and there is no air coming out of the nose. That is typical in central apnea. In obstructive apnea, the center is sending a signal to the chest to move, but the child is not moving the chest. The child is moving the chest, but there is no air coming out of the nose, and that is called obstructive sleep apnea. And the little decreased movement of the air from the nose is called hypopnea. So this is a typical pattern where I have shown the thorax and abdomen continue to move. You can see here, but there is no air coming out of the nose. This is a typical pattern of obstructive apnea, whereas here, there is no abdominal movement, there is no thoracic movement, there is no air coming out of the nose. This is very typical of a central apnea. What we normally do is we add up all the apneas and hypopneas and divide it by the total number of hours of sleep that the child has, and you get to an index. That index is called apnea-hypopnea index. If it is less than 1.5, we say it is normal. Between 1.5 to 5, mild. Anything more than 10 is called severe. Of course, nothing comes without limitations. The major limitation is availability. Almost 80% of your audience are literally telling me they don't have access. Cost is a huge problem. It can be quite expensive. There is less data on normality. Obstructive apnea just tells you the number of apneas and hypopneas. It does not tell you the effect of OSA on the child, and that's a problem. There is also some discrepancy between clinical and polysomnographic data, and therefore you need to be very good in how you interpret polysomnography in children. Okay. So some tests are very low in sensitivity and specificity. Some tests are very good in specificity, but not so good in sensitivity. And therefore, you have to use what is available to you, but be aware of what is good or not. This is the last slide telling you a algorithm. There is no one algorithm which will work for all of you, but this is a good summarization. First step is to see if the child is at risk, whether the parent supports symptoms of OSA, conditions predisposing to OSA like adenotonsillar hypertrophy, obesity, craniofacial abnormalities, etc. Does the child have clinical symptoms and signs of OSA? Does the child have any factors predicting OSA like obesity, etc.? And then you do evaluation. PSG and pulse oximetry is what is mentioned here, but I have told you the other things. And only for children with moderate to severe obstructive sleep apnea, you want to do a management. I have not spoken about management today. It's a completely different talk on its own. Thank you all. Happy to take questions.
Thank you. Thank you, sir.
Nikhil, can we have a question and answer session? Okay, fine. Anybody is having questions?
So thank you, sir, for an excellent and informative session. And again, thank you for making this one of the most underdiagnosed condition in pediatric age group patients simpler, interesting, and understandable. Again, this was a great opportunity to interact with you on this national platform through this 10th National Conference of Pediatric Allergy and Immunology, hosted by Indian Academy of Pediatrics Nagpur branch. So thank you again, sir. Thank you. So now we move on to another interesting topic, that is approach to chronic urticaria, a difficult one. And for this, we have Dr. Vinay Mehta. He is associated with Ryan Health as well as Elizabeth Regional Medical Center, Nebraska. So welcome, sir.
Thank you very much. And I would like to thank the organizers for inviting me to this conference. So what I'm going to talk to you about is a very common entity. We'll talk about chronic urticaria with a pediatric focus. So we'll talk a little bit about the diagnosis and management, and hopefully this will be a talk that will be informative and may challenge your current paradigms. So as you know, urticaria is fairly common. It's in the general population, about 25% will experience either urticaria or angioedema or both at some point in their lives. Most of the time it's self-limited. It lasts 6 weeks, it resolves. But unfortunately, about 1% develop chronic urticaria, lasting more than 6 weeks. We know that urticaria is the effector cell is mast cells. That is the main mediate. That is the main cell that drives the inflammation.
Yeah.
It is self-limited in most cases, but oftentimes the impact on quality of life is often underappreciated. So here's an example. Oh, well, first of all, before that, let's define what is urticaria. So when we talk about urticaria, these are circumscribed raised erythematous lesions. They're associated with subcutaneous edema. And the hallmark of urticaria is pruritus. So if the lesions do not itch, then it is unlikely to be urticaria. Secondly, lesions are generally symmetric in distribution. They have pale centers and they blanch with pressure. And of course, the urticaria can vary in size and shape. And so here's an example of urticaria that you can see now. That you may not be able to appreciate here, but the lesions are raised. If you were to touch it, generally it will blanch with pressure. Now, that being said, there is differential diagnoses because a lot of these rashes can look similar. So in children, especially, think about viral exanthems, very common. Think about drug eruptions. Oftentimes these are delayed, especially with antibiotics. You start a child on amoxicillin, and several days later they can develop a maculopapular rash that can look like urticaria. So that should be in the differential diagnosis. Of course, atopic dermatitis can sometimes resemble urticaria, contact dermatitis, insect bites, insect stings, erythema multiforme, pityriasis rosea, and of course, bullous pink fugoid will not occur in a child, but in adults, this is something that needs to be considered. And so one of the things that you want to do is make sure nowadays with mobile phones, everyone can take a picture. So ask the parent to take pictures so that you can fully appreciate the rash. Now, what is angioedema? So angioedema is is in the same spectrum as urticaria. It is also mast cell mediated, but it involves the deeper layers of the dermis as well as subcutaneous tissue. And so what is characteristic of angioedema is that it is non-pitting. So this is non-pitting swelling. It occurs in the non-dependent areas, so typically the face, the lips, the extremities, the genitalia. And it is commonly associated with chronic urticaria. In fact, up to 40% of patients who have chronic urticaria may also develop concomitant angioedema. In some cases, in about 10% of cases, you can get isolated angioedema without urticaria. And if this is the case, you may want to consider the possibility of bradykinin-mediated angioedema, especially if the angioedema does not respond to conventional therapies. And here's an example of angioedema, in this case involving lips, both the top lip and bottom lip. And again, in most of the time, 98% of the time, angioedema is also mast cell mediated, and you treat it just like urticaria. So how do you categorize urticaria? Well, there's acute, which means it lasts less than 6 weeks. This can occur at any age. It's short-lived. Most of the time, especially in children, it is due to upper respiratory tract infections. Probably 75% of the time it's due to infections. It can also be due to food allergies. In this case, it would be within 30 minutes of food ingestion. Drugs can certainly cause urticaria. Penicillin is a common culprit. Insect bites, insect stings, latex, and NSAIDs. NSAIDs, for example, things like ibuprofen, can often exacerbate urticaria as well as angioedema. Chronic urticaria is when the urticaria is recurrent or lasts more than 6 weeks, and predominantly this is non-IG mediated. So in the case of chronic urticaria, generally there's no role for allergy testing. And you can also have angioedema associated with urticaria. In the case of isolated angioedema without urticaria, you would normally treat in the same manner as chronic urticaria. Now, in terms of chronic urticaria, it is further subdivided. What we call chronic inducible urticaria. This is where you have where it is triggered by physical factors, for example, friction. The best example is dermatographia. When you stroke the skin with a blunt object, you welt up. So this is the common physical form of urticaria. Other examples are cold urticaria, heat urticaria, pressure-induced urticaria, and stolar urticaria. This is about 25%. Unfortunately, in vast majority of cases, 75% or more, there is no obvious trigger. And again, in these situations, angioedema can also occur up to 40% of the time. Now, what is also unique about chronic spontaneous urticaria, and this is an important concept to understand, is that antihistamine therapy alone will give you only about 50% of patients will respond to oral antihistamine therapy, even at quadruple doses. So many times oral antihistamines alone may not be adequate. And so you may need to step up therapy. Whereas with acute urticaria, most of the time, all you need is antihistamine therapy. So what is the approach as a clinician when you see a child with recurrent urticaria lasting more than 6 weeks? I think the first thing is you really need to take a history, take a very comprehensive clinical history. You want to rule out mimickers of urticaria. You want to make sure the child does not have underlying systemic disease. So you really want to focus on what are the signs, what are the symptoms associated with urticaria. Duration of individual lesions is important. Typically in urticaria, the lesions only last 24 hours, maximum 48 hours. If each individual lesion lasts more than 48 hours, you may be dealing with vasculitis. So this would be an indication for a skin biopsy. You also want to inquire about accompanying angioedema, especially if the child has laryngeal angioedema that can be potentially dangerous. In this situation, you actually would want to prescribe epinephrine to keep on hand. And then you want to have some sort of assessment of disease activity. And one of the standardized scale that we use, tool that we use, is the urticaria activity score. This gives us an objective measurement of disease activity. And there's another scale, urticaria control test. This is similar to the asthma control test, but for urticaria, it gives us an idea of how well the urticaria is controlled. And then you want to look for clues of systemic disease. Also important to recognize that patients with chronic urticaria, oftentimes physical factors can make the urticaria worse. So for example, heat, pressure, sweating, friction, similar to the inducible urticarias, oftentimes there's some degree of overlap. So you want to minimize heat, minimize cold, minimize sweating, minimize friction, have the child wear loose clothing. Also, NSAIDs in the context of chronic urticaria often can worsen symptoms in quarter of the time. So can stress. So both physical stress as well as psychological stress. So oftentimes the children will get anxious or lack of sleep, and that stress alone can aggravate hives. And then foods. A lot of times, this becomes there's a little bit of controversy regarding diet, but we know that certain foods, especially spicy foods, can aggravate hives. Perhaps foods rich in histamine can also aggravate hives in a child that has pre-existing urticaria. And so we generally recommend no spicy foods, no foods rich in histamine. And in the case of adults, no alcohol, because alcohol can also not only cause vasodilatation, but it can also degranulate mast cells and aggravate the urticaria. So this is the urticaria activity score. This is a tool that I would encourage you to use. This is an objective way of measuring disease activity. Basically what this is it's a daily assessment of both urticaria as well as pruritus. And it's scored from 0 to 6 every day. So you score, 0 would be no highs, 1 would be mild highs, 2 moderate, 3 intense. And then you would also rank or rate the pruritus, 0 being no pruritus, 3 being intense pruritus. And so every day you the maximum score out of 6, and then you do this for 7 consecutive days, and it gives you a maximum score of 42. So this is, I think, a good way of actually objectively measuring or assessing urticaria activity. And then there's also another tool called the urticaria control test, which just gives you, and this is a recall over the last 4 weeks. So basically you ask the patient or you ask the child in the last 4 weeks, how much have you suffered from the urticaria or swelling? How much has your quality of life been affected in the last 4 weeks? How often has the treatment of urticaria in the last 4 weeks not been enough? And then an overall assessment of urticaria control in the last 4 weeks. And so in this case, this is scored out of 16. And to have well-controlled disease, you need to score at least 12 out of 16. And this is used in the context of determining whether you need to step up or step down therapy, similar to the asthma control questionnaire or the asthma control test. So beyond clinical history, beyond assessment of disease severity, what other investigations? Well, for the most part, there are no routine investigations. Unless there's a compelling history, for patients who have a normal history, normal exam that lacks atypical features, there's really no lab workup that is necessary. However, just for screening purposes, in the guidelines, they do recommend perhaps checking CBC with differential, either SED rate or CRP, and a TSH. What can you glean from CBC? Well, if the eosinophil count is quite high, then you may want to investigate for parasitic infection. If the white count is high, you may want to investigate for bacterial infection. If your SED rate is high, if your CRP is high, that should prompt perhaps further investigations looking for a systemic disease such as an autoimmune disease, a rheumatological condition, infection, or underlying malignancy. And if you have an abnormal TSH, that should prompt evaluation for thyroid disease, either hypothyroidism or hyperthyroidism. And so generally, these are the 3 labs that we get as screening, but again, it is not necessarily in patients who they don't have any atypical features. When to get a skin biopsy, there are certain situations where you may want to get a skin biopsy, and this is essentially to rule out urticarial vasculitis. This is when you have individual lesions that persist beyond 24 to 48 hours. If the lesions are painful rather than pruritic, if there's accompanying petechia or purpuric characteristics, or if they leave bruise. So these are all atypical features, generally with general garden variety urticaria will not have these features. So if you have any of these features, that would be indication for a biopsy. Or if you have a very high SED rate, or if you have systemic symptoms like arthralgias or fever, again, this is not typical of garden variety urticaria. And so this is where you may want to get a biopsy to rule out vasculitis. So in terms of management, once you've made a diagnosis, once you have ruled out systemic diseases, you've ruled out mimickers of urticaria, how do you treat urticaria? These are the treatment guidelines, and I would encourage you to read up more about it. These are actually international guidelines. They were just updated this year in the month of March. And so basically, the algorithm is you start out with a 2nd generation antihistamine. You start out with a standard dose. If the hives are not adequately controlled, then you quickly escalate the dose to 4 times the dose of the 2nd generation antihistamine. And if you're still not well controlled, and unfortunately with chronic urticaria, up to 50% of patients, including children and adolescents, will not be well controlled even with 4 times the standard dose of antihistamine. So in that situation, you may want to consider omalizumab. And if that is not available or not practicable or not affordable, the alternative would be cyclosporin. So let's go through these guidelines very quickly. So first step is a 2nd generation antihistamine. So that is absolutely the first line treatment for all types of urticaria, both acute and chronic. Examples of 2nd generation antihistamines are listed here. And the dosing is it really depends on the age of the child. You start out with a standard dose, but you quickly increase to 4 times the dose if the child's hives are not well controlled before you add any other therapies. The other thing I want to mention in the new guidelines is we don't recommend combining different H1 antihistamines. So, just pick one antihistamine, use the same antihistamine up to 4 times the dose. There's really no evidence that combining 2 different 2nd generation antihistamines is any better than a single antihistamine. So for all practical purposes and also for simplicity, I would just pick one, your favorite non-sedating antihistamine. Start out with standard dose, but quickly escalate to 4 times the dose. The other important thing, which is also mentioned in the guidelines, is that 1st generation antihistamines are no longer recommended. Things like hydroxyzine, things like diphenhydramine, they are no longer recommended due to its effect on sleep. So it actually impairs REM sleep, and it also leads to poor cognition. So especially the child that goes to school, if they're sedated, then they don't learn well in school. It's associated with poor performance and poor learning scores. So if possible, do not use 1st generation antihistamines unless if you deliberately want to sedate the child. Assuming that 4 times the dose of non-sedating antihistamine is not sufficient, then the next step would be omalizumab. You may be familiar with omalizumab. It's a monoclonal antibody directed against IgE. And the way it works is it binds circulating IgE, irrespective of its specificity. And so by binding IgE, it basically renders it inert. And it actually reduces the free Ig that's in circulation. How this works is if you look at the mast cells into the basal cells, you have on the mast cells Ig receptors on the surface, which are directly proportional to the level of serum, free serum IgE. So by binding free IgE, you reduce, or sorry, by binding IgE, you reduce the quantity of free Ig in circulation. Therefore, you downregulate the what is called high affinity epsilon R1 receptors on mast cells and basophils. These are Ig receptors. By downregulating the number of Ig receptors, you essentially reduce the risk of mast cell degranulation and basophil degranulation. And so that is the underlying mechanism of how omalizumab works in urticaria. You essentially reduce the threshold, or you increase the threshold for mast cell degranulation. And so omalizumab is, in most countries, can be used in children 12 years and older who remain symptomatic in spite of quadruple antihistamine therapy. Again, it reduces Ig receptors on mast cells, so it increases the threshold for mast cell degranulation. The dosing is 300 grams sub-Q every 4 weeks. This is independent of serum Ig level and independent of body weight. Because omalizumab can potentially cause anaphylaxis in about 0.2% of cases, patients should carry epinephrine at all times. And so this is important. Also important to dose the first 3 injections must be done in the office. And subsequently, if patients have no reactions, they can dose at home. Now, in the guidelines, there is a mention that you can actually increase the dose. So you start out with 300 grams every 4 weeks, but if that alone is not adequate, you certainly can increase the dose and also shorten the interval in between, or both. So you can actually give up to 600 grams every 2 weeks if the standard 300 grams every 4 weeks is not adequate. The downside is that the more omalizumab you give, the more expensive it becomes. So this may not be a practical issue. Here are some examples of the effect of omalizumab in chronic spontaneous urticaria. So you have 323 patients, non-responsive to antihistamine therapy, and these patients were randomized to either placebo or various doses of omalizumab. This was given every 4 weeks for the first 8 weeks. So at week 0, at week 4, at week 8. And you can see that in both the 300 milligram arm and the 150 milligram arm, you saw a substantial reduction in the number in the itch severity score. This generally occurred within 2 weeks. And unfortunately, when you stop omalizumab, after a few weeks, you have reversion back to the mean. So omalizumab is not disease modifying. It works for urticaria, but once you stop within a few weeks, you're right back to square one. So this is looking at itch severity, and then this is looking at number of hives. So again, you see with omalizumab, within about 2 weeks, you see a substantial decrease in the weekly number of hives. But unfortunately, once you stop the drug, within a few weeks, you revert back to reversion back to the mean. So what to do if omalizumab is not a feasible option, or if patients don't respond? Because about 2/3 of patients, even on high dose omalizumab, they still will not respond. And so the next step would be to add, on top of the 2nd generation antihistamine, up to 4 times the dose, to add cyclosporin. So cyclosporin, as you know, is a calcineurin inhibitor. And what it does, it blocks calcium-dependent release of not only histamine, but leukotrienes and other mast cell mediators. The advantage of cyclosporin, it has a fairly rapid onset of action. And actually, in terms of efficacy, it's actually comparable with systemic corticosteroids. And unlike omalizumab, there's actually a potential for lasting remission after treatment is discontinued. So this potentially can actually induce remission, whereas omalizumab does not. The downside of cyclosporin is there's potential for hypertension, there's potential for renal insufficiency, and there's also potential for hirsutism and gingival hyperplasia. So these are the side effects of cyclosporin. We generally avoid it in patients with chronic kidney disease or fully controlled hypertension. The good, fortunate thing is that these things are rare in the pediatric population. And the dosing is generally between 3.5 milligrams to 5 milligrams per kilo per day. It can be used, generally we don't like to use it under age 12, but it certainly can be used. And I know, in rheumatology, we use cyclosporin at a relatively young age. The precautions with cyclosporin is you need to monitor the child's blood pressure, and you need to monitor BUN creatinine because it is metabolized by kidneys. This has to be done at least on a monthly basis. And there are some cautions with potential P450 interactions with other medications. Fortunately, in children, you're not going to see statin use, and you're not going to see antifungal use, generally speaking. So these are the drugs that potentially interact with cyclosporin. Once you achieve complete control for 3 months, you can generally wean off cyclosporin over several months. And so in most cases, 6 to 9 months of treatment is adequate and will cause remission in most children. Oral corticosteroids certainly can be used, but if you use it, please use it only short term to gain temporary control of symptoms during severe exacerbations. Also keep in mind that you can get rebound urticaria once you stop the steroids, and we see this quite often. So if you're going to, so therefore don't abruptly stop the steroids. You want to gradually taper over a few days. If the hives come back, you can then return, you would go back up on the steroid, return to the last effective dose, and attempt to taper again, but more gradually. And certainly long-term corticosteroid use is discouraged, especially in children, as you know, has many side effects, including growth stunting. So in terms of treatment and algorithm, and one thing I failed to mention is that the average duration of chronic spontaneous urticaria is between 2 to 5 years. So this is a disease that will be present for several months, if not several years. And so the way you decide if you want to step up or step down is based on the urticarial control test. Remember that a score of, you want a score of at least 12 for it to be well controlled. And so anything under 12 means it's uncontrolled, which would mean step-up therapy. If it is extremely well controlled, then you can step down therapy. And so generally this is done every 3 to 6 months. Based on the urticarial control test, you can either step up or step down therapy. So just to summarize, chronic spontaneous urticaria is defined by the presence of urticaria, angioedema, or both for a period of 6 weeks or more. This can be daily, but this could also be recurrent. There is no laboratory testing necessary in most cases. Keep in mind that half of your patients with chronic spontaneous urticaria will not be adequately controlled, even with 4 times second generation H1 antihistamine therapy. And so consider adding omalizumab if it's feasible. If it's not feasible, then consider adding cyclosporin. Certainly systemic corticosteroids should not be used long term, but if you need to gain temporary control, you can use them during severe exacerbations. And so with that, I will end. And again, I want to thank the organizers for inviting me. And hopefully this talk was informative. Thank you very much.
Thank you. Thank you, Dr. Mehta sir. Actually, it was a very informative talk, and day by day we are encountering the new type of patients regarding the schemes. It may be acute or chronic, but you have simplified your talk by telling us what is acute, what is chronic, and
Yes.
you have also highlighted the importance of arterial activity score, that is UAS7 score, and how to arterial control test, and how to
Yes.
approach such type of patient, how to investigate, and how to start the treatment. So thank you, sir. There only one, my question is that, are there any side effects of omalizumab you have just highlighted in your talk? So apart
Yeah.
from anaphylaxis, are there any other side effects?
No, and I mean, not really. I mean, I think the other, aside from anaphylaxis, there may be injection site reactions. So at the site where you inject, there may be some pain, erythema, tenderness. Occasionally, we see myalgias or arthralgias that are transient. But generally, this is something that's seen in adults, not so much in children. And keep in mind that omalizumab has been around for approaching 20 years. At least in the United States, has been available for nearly 20 years. So we have a lot of experience, not only in chronic urticaria, but also in asthma, and also in chronic sinusitis with nasal polyps. So I think generally it's very safe. The only, and I personally have not seen any cases of anaphylaxis, but it is reported in 0.2%. And so for that reason, if you do prescribe omalizumab, you want to make sure that the patients have epinephrine autoinjector. If not, and if autoinjector is not possible, and I know in India it's difficult getting an autoinjector, then I would recommend just drawing up the epinephrine in a pre-filled syringe, and then putting it keeping in a spectacle case, protected from sunlight. And generally, that it should be good for at least 3 to 6 months.
Thank you, sir. Thank you. Over to organizer.
Okay, thank you.
Hello, sir. I had one question. Thank you for covering this topic in depth, and you are almost covered each and everything in the chronic urticaria. You said only one antihistaminic should be prescribed. It might be fourfold, but combining the antihistaminic is not a rationality. But if we do like this, if the patient is very restless and the parents are very anxious, combining second degree antihistaminic in the morning and the first degree in the night, will it be a rational or irrational combination? As far as the children's in the lower age groups are concerned, but the parents are very anxious if they're not sleeping.
Yeah, I mean, it can be given, but just be aware of side effects. So if the child goes to school, just keep in mind that, well, first of all, they're with first generation antihistamines, you'll have anticholinergic side effects. So that's, dry mouth and impaired cognition. And in fact, at high doses of first generation antihistamines can even be toxic potentially. It can actually prolong QTC interval. So be careful not to overuse first generation antihistamines. But certainly if the child is restless, we sometimes use it at night, but generally not during the daytime, because you don't want to sedate the child. But as far as efficacy, there is no evidence that first generation antihistamines are any better than second generation antihistamines. But if you want to use it for sedating purposes, then that's fine, that's appropriate.
Thank you very much, sir. We would request our chairpersons and Dr. Kiratkar sir, Dr. Sanjay Deshmukh sir, and Dr. Khatwar sir for a group photograph on the stage. Out of interest of time, we would restrict the questions. Probably the physical sessions can be discussed over a tea or coffee or during the lunch break.
All right, thank you, everyone.
Thank you. Going to the next session, I would request our chairperson, Dr. Yashwant Patil sir and Dr. Yogendra Javadekar sir to come on the stage, please. Over to the chairpersons. With the interest of time, I'd request everyone to kindly take their questions during the lunch time or during the break in person with the speakers. Thank you very much.
Good morning to everybody. At the outset, myself and Dr. Javadekar, we extend our sincere thanks to the organizers for giving us chance to chair this session. The session is of 2 lectures, which will be covered by Dr. Jose and Dr. H. Paramesh sir. First of all, Dr. Joseph is our friend, my co-EB member from Kerala. He's a well-known pediatrician from Kerala, and whatever he is going to tell us, recently now in the last lecture we have heard about some H1 first line and second line antihistamines. But now he will give overall review of all antihistamines to be used in the pediatric practice. His topic is newer antihistamines. Over to Dr. Jose.
Thank you, sir. At the outset, I take the opportunity to thank Dr. Vasant Kalakar, Dr. Rajkumar, and senior members of Nagpur branch, taken the challenge of organizing our allergy conference, national conference in a fantastic manner with very good, excellent scientific content and fantastic arrangement for these programs. As already we are running short of time, already the 50% of my talk is covered by the previous 2 or 3 speakers regarding the antihistamines. Various discussions are over, so my job is very easy. So what is the relevant of topic of antihistamines is concerns? So antihistamines are one of the most common drugs prescribed in a pediatric practice is concerns. According to the International Medical Statistics Guidelines show that there is around 2 million pediatric units antihistamines worth $6 million were sold in the year in 2016. Of which 1/3 of it is utilized by the first generation antihistamines for which no pediatric safety and trials are done before. So as you know, the histamine release due to the anti-stick on the muscles, explosive generation of muscles with basophils sensitized with IgE upon unexposed antigens. There is no release of histamines in the chemical or mechanical release from the muscles. Once the histamine is released, it is metabolized with the 2 pathways to the N-methyl histamines and imidazole acetylates. So in the human body, there are a lot of histamine receptors are situated in the various organs. So more of which histamine receptors can be classified into H1, H2, H3, and H4. Of which H1 and H2 are important for all of us concerned because H1 is concerned with all our allergic inflammatory disorders and H2 is concerned with gastric acid secretions. So the target organ where the H1 receptors are there, in the CNS there is a pain, H1 there is a pain and itching sensation and have a triple response with red, wheel and flare response. And H1 and H2 can have effect on the appetite and satiety. H3 is a reduced release of acetylcholines, amines, and peptide transaminase. And its effect on the cardiovascular system, histamine, they're having vasodilatations, falling BP, and rising heart respiratory rate. And the lungs, you have H1 receptors have due to bronchoconstrictions and And the GIT, there will be H1 contraction in smooth muscle can lead to diarrheas, and secretory tissues H2 produce secretion of gastric acid, and metabolic effect of the H3 can have increased food intake and obesity. What are the histamine antagonists? We have considered there is a physiological antagonist like epinephrine, and there is a release inhibitor like a chromoleum sodium there, and they're having a receptor antagonist that we are more concerned regarding H1, H2, H3, and H4. As far as we are concerned, we are more concerned here regarding H1 and H2 antihistamines. So regarding the H1 antihistamine, there are a lot of generations are available now, of which first generation, second generations are important for antihistamines concerned. Regarding the first generation, already we discussed having a property like lipophilic, low molecular weight to cross big tendency to cross the blood-brain barrier, and potential side effects are sedations, hyperactivity, insomnia, and convulsions. And it usually requires frequent administration at least for 2 to 3 times. And another important aspect of a first-gen antihistamine is considered that there is no RCT trial, especially in pediatric or placebo control, is not done for a first-gen antihistamine concern. And second-gen antihistamine concern, does not cross the blood-brain barrier, so there will be no sedation, no CNS hyperactive symptoms. The most of the second-gen antihistamine we can advise once in a or twice daily. And there are a lot of RCT studies prove that it is clinically efficacy in various allergy disorders in pediatric practice is concerned. So these are the first generation antihistamine again classified into highly sedative, moderately sedative, and mild sedative antihistamine first generation is concerned, because this is not going to discuss furthermore. And second generation antihistamines, we are more concerned regarding the most important one was cetirizine and levocetirizine. And cetirizine we can use above 6 months of age onwards. Levocetirizine also we can use above 6 months of age onwards. And fexosinidines we can use above 6 months. Now the type 1 you can use younger age group, and usually recommended between 2 to 12 years of age. Loratadine we can use by about 1 to above 1 year of age. And dextromethorphan can start from 6 months to onwards we can use various combinations. And these are the new other antihistamines. Acetylastins we can use recommended. We can between different as a nasal spray. It is available. And misulastatin you can use only recommended about 12 years of age. And Avastin is a drug we can use between above 6 years of age. And according to the age of the child, we can use the doses changes. And ribapatidine also is recommended between the age of between age 2 to 12 years of age. So acetylastine is actually the phthalate derivative is available as a nasal spray. So acetylastine mast cell stabilizing property that prevent release of interleukin-6 and tryptase, histamine, and TNF-alpha. So it usually used the acetylastine used for allergy rhinitis, vasomotor rhinitis, and allergy rhinoconjunctivitis is usually used. And acetylastine nasal spray is available as clinical use. About 12 years we can use 1 to nasal spray per nostril per PD, 2 divided doses. And 5 to 11 days we can use 1 nasal spray per nostril. So not approved. Fact is that acetylastine not approved less than 5 years of age. Major side effect is acetylastine is a bitter taste, so the patient child may not be tolerated in most of situations. And olaparib is already we discussed today regarding allergy conjunctivitis. He has another drug approved for above 6 years of age. Misulatin is a long-acting H1 antihistamine. Usually uses are recommended as seasonal allergy rhinitis, perennial allergy rhinitis, and chronic urticarias. Again, all the same pattern of adverse effect of antihistamines like dryness of mouth and other dizziness, headache, and other common side effect antihistamines are similar to the antihistamines are there. And again, it's also recommended that misulatin also recommended about 12 years of age. Ribapatidine is a new drug. Is usually it is a selective antihistamine receptor antagonist, and platelet have 2 properties, and platelet activating antagonist also. It is also recommended seasonal allergy rhinitis and perennial allergy rhinitis and chronic spontaneous urticarias. And it is usually one of the advantages. It is usually rapidly absorbed from the GIT. Emax is 1 hour. It is metabolized and it metabolized like a desoratadine and hydroxide form of dextrolatadines. Another important factor, the metabolism of ribapatidine is decreased if you are co-administered along with the acetaminophen. So recommended age group is between 2 to 11 years. The recommended is that above more than 25 kg, we can use 5 ml as OD. And between 10 to 55 kg, we can use 2.5 ml SOD. So available as solution is 1 ml, 1 milligram per ml. And there is no study below 2 years of age, not recommended, so it's not recommended. And about 12 years age, we can use adult dose at 10 milligram as a single dose. Ebilastine is also the common new drug we extensively use in pediatric practice is concerned. It is a piperidine derivatives, active metabolites, carbastins. So common indications for ebastins are allergic rhinitis and chronic urticarias. And the adult can use between 10 to 20 milligram as a single dose, and children above 6 years recommended is a 5 milligram as a single dose. One thing is that ebastin, you have to be, there is strict contraindication for ebastins concern chronic liver disease and long QT syndrome like any antihistamines. And common adverse like a headache, dry mouth, drowsiness and nausea and weakness are the common side effects of ebastin concern. Regarding the pharmacokinetic of antihistamines concerned, all antihistamines are well absorbed for oral administrations. Maximum concentration occurs in 1 to 4 hours, and the plasma half-life depend upon the drug metabolism and clearance and within the bodies. So you can use all the first generation antihistamine, almost the second generation metabolism liver by cytochrome B450 enzymes, and cetirizine, levocetirizine are eliminated urine. So here having a renal failure shall need a renal dose adjustment in case of a cetirizine liver. Cetirizine is concerned, hexafenadis is metabolized liver. So again, the chronic liver disease, you have to be cautious in prescribing hexafenadis in a CLDL. So all the antihistamine properties are discussed in the previous talk. There is a CNS effect, muscarinic effect, and serotonin receptor activity, alpha adrenergic receptor activities, and cardiac. So it is not having a multiple side effect. So this is not commonly recommended. And there is no RCT trial in pediatric age groups. So commonly the antihistamines are recommended. The only 3 conditions are commonly recommended for allergic antihistamines concerned. One is allergic rhinitis, allergic conjunctivitis, and urticarial lesions. And that's the second generation antihistamines are drug of choice. Weak evidence for second generation antihistamines like atopic dermatitis already we discussed, and anaphylaxis and other indications. The weak evidence of indication of first gen antihistamines like other usually we don't recommend for first gen antihistamines. So FDA recommendation for one first H1 antihistamines are allergic rhinitis, allergic conjunctivitis, sinusitis, urticarias, angioedema, atopic dermatitis, and motion sickness. The most commonly we use antihistamines in allergic rhinitis because most frequent chronic disorder in a pediatric age group is concerned can lead to the development of laterally to the other long-term sequelae is allergic rhinitis. He said second generation antihistamine is a drug of choice, effective in allergic rhinitis, especially child having or can oral antihistamine can reduce the sneezing, rhinorrhea, and ocular symptoms of allergic rhinitis. So usually recommend in a mild intermittent disease available as a ophthalmic, even rhinoconjunctivitis, we can use ophthalmic preparation of antihistamines are available. And again, we can use intranasal antihistamines are available. No clinical studies in children involved in first gen antihistamine is not recommended as first line therapy of So regarding urticaria, already we have extensive discussion regarding the urticarial line of management. H1 blockers are a first line therapy. Usually second generation such as loratadine, esoratadine, fexofenadine, acetylene, and levocetirizine are the drug of choice we have to recommend. So again, the clinical trials are sufficient to determine that if one antihistamine is superior to another. And again, there is a approach of chronic urticaria we all discussed when we had to give for first week, you had to give the start with the second gen antihistamine and wait for response for 2 weeks. If there is no response, we can increase to 2 to 4 times dose of same antihistamine. Combination antihistamines also not commonly recommended. You can increase maximum up to 4 times of recommended. Again, you have to consider for a other mode of management of an urticaria is concerned. So allergic rhinitis again the topical antihistamine like a topical olapatide goes or you can do levocarbastin or acylastine or drops are available for the topical aspirin allergic conjunctivitis. So the taken usage of antihistamines concerned, antihistamines are one of the most common drug selling without prescription in the worldwide. And the first generation do not have any safety trial in pediatrics is concerned. First antihistamines are recommended, not recommended for use in children because of sedative effect and impairing learning and school performance. And use of or counter cough and cold medicine medication containing antihistamines in young children have been associated with serious side effects and even the mortality is very high. So second generation antihistamine is a drug of choice recommended for any for allergy disorder pediatric concern. Thank you for presenting. Thank you very much.
Thank you, Dr. Jose. It was within time and very short and brief, very informative blood. So you have elaborated all the newer antihistaminics. Out of that, what we want to know, most of them, they are more than for 2 years of age. But what about in infancy and less than 2 years of age? Which are the safest?
6 months onwards, we can use levocetirizine, and cetirizine we can above 6 months we recommend it.
Okay. So any questions? Okay. Now we'll switch over to the second lecture. Sir.
I would like to invite Dr. H. Paramesh, who happens to be an eminent personality in himself. He has been a practicing pediatric pulmonologist for the last 35 years at Bangalore. His present designation is Visiting Professor of Divecha Center for Climate Change. His affiliations are to WHO spokesperson for COP 2621, Adichudananda Giri University, I hope I have pronounced it correctly, Rajiv Gandhi University of Health Sciences. His major achievements have been local, state, national, and international awardee for his work in environmental and health. 731 invited scientific papers and talks, 46 oration awards, and he has contributed to more than 42 textbooks with his chapters, more than 100 publications to his credit in national and international journals. One of the reviewers for the Mega Science Vision 2035 climate research. So he give him a big round of applause. He needs to
add into that, I think he is the only pediatrician who is known as an environmentalist at the world level, at WHO level. And he is our most dynamic, ebullient, and quite academic, doing academic activities in our COMAD organization. And he represents our COMAD as a national president of COMAD. Thank you, sir.
We have the privilege to have you here, sir.
Thank you, sir. I think 20 minutes or 25 minutes. Earlier it was 25 minutes. I think anyway, I'll try to finish it out. Okay, fine. I'll try to adjust myself.
Sorry, sir, we are running short of time.
Yeah, fine, sir. Fine, sir. I'll adjust. Earlier you said 25 minutes. That is why I wanted to make sure. Well, respected chairperson, thank you very much. Kind introduction. My brothers and sisters of IAPNs, national level, state level, local level, and brothers and sisters of the IAP, allergy, asthma, immunology chapters. I think thank you very much. At the outset, I extend my sincere thanks for the organizer for giving this opportunity to come and share some of our thoughts with you. And also I bring the greetings from the Institute of Science, Bangalore. It's a 113 years old institute and 480 acres of land in this one. We have a beautiful greenery. And now the topic was assigned is impact of the environment and allergic diseases. So now, before we go, what are the impact environmental issues and allergic diseases? I like to sensitize few things about the allergic diseases. Now, you know very well that communicable diseases coming down from 1990 to 2016, according to the government of India's data, the non-communicable diseases is increasing. So airway allergies are the earliest onset communicable, non-communicable environmental diseases with significant psycho-socio-economic health burden. Allergic diseases are at the global epidemics as of 2015 WHO report. 6.2% of the global economics burden, yes. I think this, I cannot see very well in this one. Can we make it a little bigger here, please? Sorry for the inconvenience. Okay. It's very short, is I cannot really. Full screen, if you make it, I'll be very thankful. Make it full screen. Okay. Lungs bear the brunt of the air pollution, environment change directly or indirectly through the gut and lung axis, and also from the skin and lung axis. Now, why this allergic disease is increasing all over the world is only imbalance. Imbalance of what? Imbalance of losing our threshold of protection, what nature has given earlier over the years by depriving the protective germs in our environment, changing our traditional food habits, and adapting to the Western lifestyle of living without any sunlight inside, without cross ventilation inside. And in addition to that, there is a higher exposure to the triggers, such as air pollution and climate change, and increase in the viral infections, and less access to the health facilities. So 3 important things the air pollution should worry about is suspended particulate matter 2.5 micron, tobacco smoke, and ozone. So environment pollution have an impact from womb to tomb. And the placental coagulation syndrome causes this new thing, fixed airway obstruction in fetus who are very prone for recurrent wheeze, bronchiolitis, and persistent asthma. Later on, they're going to obstructive sleep apnea syndrome and COPD later on. So air pollution, agriculture, food, microbe contribute to early immune programming and development of the fetus by epigenetic changes, which has lasting effect on the child's life. Now, I think as we go, as the infant grows, lung also will grow in terms of branching, numbers, and also in the size, up to 8 years. After 8 years, when they reach adulthood, then the lung function slowly, it will come down to the tune of 15 to 20 ml per year. In an asthmatic, it is going to be more in that one, and also it is non-reversible. It more so happens in premature babies, more so happens small for dead babies, and rapid weight children who are going the rapid weight gain in the first year of life. If you look at some of the magnitude of the allergic diseases in India, this is the late Nagaraju's book we have contributed together, and allergic rhinitis is up to 50%. Asthma is 28%. Our own studies, ICMR studies, Sukumaran studies is there. And average 28% of children less than 18 years have got asthma. And atopic dermatitis is also 2.7% in the age group 6 to 7%. Urticaria 7.8 to 23%. Food allergy 68%. Anaphylaxis and less than 1% in the lifetime period. Is it a genetic pattern or environmental pattern? Recent study shows from the Lancet, it more looked like an environment issue more than the genetic pattern. This same thing we had at 2002 of our 20 years of study. We published 2002 the same thing because same genetic stock in the urban area, same genetic stock in the rural area. We found out the urban people suffer much more than the rural children. Now, coming to the subject, environment allergic diseases. The environment is the natural surroundings we exist or live in relation to their physical characteristic or weather condition. Air pollution, global warming, climate change are all interrelated. How they influence allergic diseases and comorbidity will be highlighted among eight headings. Which in first one is the air pollution. With certain proof, we are going to document it for you. Now, air pollution, which has got both outdoor, indoor air pollution. You cannot separate one from the other completely. However, we have enough epidemiological data in the world to say that outdoor air pollution have children with heavy traffic school, they suffer much more than rural school. And urban children suffer more than the rural children. And asthma in increase in summertime from 2% to 28.5%. Traffic police, double the number, they suffer. And slow traffic, 10 km/h produce more carbon monoxide than the 75 km/h because the increased number of vehicles. Asthma visits emergency room is increased 100% during Diwali times. And allergic rhinitis and comorbidities, otitis media and sinusitis, comorbidity has significantly increased. And outdoor air pollution mortality has increased 113% as of recent study for ICMR published in the Lancet. How about indoor air pollution? What data we have it? We have the use of the biofuel in ill-ventilated houses change the sex ratio. Usually boys suffer more than the girls. In this situation, girls suffer more than the boys, almost 2:1%. And prevalence of ill-ventilated house is about 47%, when compared to well-ventilated house is only 8%. And use of non-commercial cooking fuel using cow dung and agriculture waste is 48%. Nearly children have asthma in that house. When compared to the using the electricity is only 1.2%. Clean energy. Single parent smokes in that house, there is 3-fold increase in asthma in that house. And mosquito coil produces about 7,500 cigarette equivalent of the pollutants. And single room dwelling with agriculture waste as a cooking fuel has 10.5-fold increase in pneumonia. Indoor air pollution mortality has come down significantly up to the 64% as of 2021 ICMR study. Now, what other proof we have? This is the study done in Mexico where they taken nasal mucosa, electron microscopy. They found out children from the polluted area in Mexico, non-polluted in Veracruz. They found all the parameters are abnormal. Pollution has got. In addition to that, in Dr. Kulkarni, she had done in England, she took the healthy children, made them to cough, get the phlegm from inhalation of 3% saline, and those phlegm, she found out the macrophages, finding out how many carbon particles are there in that one. Depending on the number of particles, the lung capacity significantly has come down. Much more so in a small airway, which is a silent zone. Unless you do the complete pulmonary function, you cannot find out. Having that kind of proof, we have enough proof for that one. The traffic-derived air pollution, we told about it. Whenever the less than 2.5 micron, 1 micron, passes the lung, enters the bloodstream, there is small platelet aggregation, multiple clots will form. Depending on the severity of the clots, the placenta get nutrition. Those children end up stillbirth. If it is less, you have prematurity. 30% of the children have prematurity. And if it is little less, small for dead children, they are the one going to have fixed airway obstruction we highlighted already. And these children in future have to recurrent wheeze, recurrent bronchiolitis, and asthma. And around the world preschool has increased all over the world. 2017, the Lancet editorial board selected 8 global experts. I was one of representing Indian subcontinent. We highlighted that in India, we have 77.5% children under 5 are the wheezer. In that one, 26% come from the first year of life. And we recommended to use the bronchodilator in a situation, investigate before the investigation. And my own friend has done in Poland. He found out when the suspended particulate matter 2.5 micron from 35 to 53 is gone, there is 4-fold increase in the recurrent wheeze and asthma in that. And environmental living in the main street, they are 4-fold higher sensitization for the pollens. And also the 70% of them have got significant skin test positivity. And atmospheric pressure, if you go higher, the atmospheric pressure is less. The oxygen is only 20%. But what happens, the molecules are quite white. When the atmospheric pressure increases, the pressure will come down. When a given volume, the pollutants will be very high, then the asthma, it will trigger. Now, the summertime is increase in asthma from ozone production. And this is the study has got 1994 in Bangalore, 2.8%. Now in 2009 is a 28.8% asthma. That is from the slow traffic, red light where it comes, and sunlight, a lot of production of the conversion of the secondary formation, secondary ozone, and bright sunlight contribute. Wind velocity is much less. that concentrate. So I think pollen has also increased in adaptive global warming from 3 reasons. Increased carbon dioxide for the prolonged flowering of season, and allergic pollens becomes more, as you can see it here. And also new pollens will be formed in these plants, ambrosia, and new allergies will form. And when the global warming says the sunlight produces more ozone, in addition to that, trees also go under stress. They produce propylene. That produces more power in the protein content of the pollen. And if they are deposited diesel particle, they are 50 times more potent. Having said that, for change in the humidity, there is increased humidity, and warm temperature increases allergy from the dust mites. Decreased humidity, increased temperature increases the pollen allergy. Increased humidity, decreased temperature increases the fungal allergy. And seasonal allergy, what we have winter season, December to February, dust mites and mold, weed pollens will be very high in November to January. And in summertime, March to June, we have tree pollens are carried from the many, many miles. As a matter of fact, ozone production also will be very high. In monsoon season, allergy is much less. And predominantly, if it's allergy, it comes from the grass pollens. In post-monsoon, usually agriculture burn, especially in November, December, and Delhi people, they suffer the most. Mainly 90% of the burning come from the Punjab and 10% come from the Haryana. They suffer the most. And thunderstorm, definitely what happens during this condition, the thunderstorm, the pollen grains, after they will rupture, the asthmatic shock, they will attach small particle, the allergy will be very high, emergency department will increase 100% increase at that time. And one of the fungus, we bloom during the thunderstorm. And drought and allergy, the asthma will be triggered mainly for 2 reasons. More dust, particulate matter triggers smog and all this thing. And also the more smoke from the wildfires will be increased. Wildfires has increased all over the world. That is produces more smoke and allergy. I think we'll go from that one. Now coming to the last one, environmental care. So occupation of the parents. I think child labor is prohibited in 1986. And also, if at all have to work, only in the agriculture field with their parents they work. And parental occupation have an impact on childhood asthma through the environmental issues. So I think this is what we already highlighted in our own study, where the girls are helping the mother in cooking using the agricultural way, they suffer the most. And maternal asthma affects the children. 4 to 12% pregnant women have asthma globally. They have adverse risk reaction like adverse parental outcome, higher incidence of prematurity, low birth weight, small for gestation for babies, increased risk for cleft lip, and increased risk of infections and parasitic disease, increased risk of nervous disease, increased risk of upper and lower airway disease, and increased risk of skin problems. The pesticides, when the farmers they use in the field, early life exposure is shown organophosphorus have got effect on the children's lung function and triggers asthma also. Pesticides are associated with both atopic, non-atopic weeds is a high risk factor for asthma in children. The children who are working in their father in the garage, they tend to suffer the most from the lead poisoning. Earlier, we never knew lead has got an effect. Now we found out lead contribute for the lung function also. We'll go next slide, we'll see that. And the classroom where facing the way the automobile's background, when they start, the smoke enter the classroom, those children have suffered, studies are available. And lastly, children coming from the heavy traffic school, they suffer the most. We have some data in related to that. Lead poisoning in the air decreases the FEV lung functions. We never knew earlier. Recently, we knew, we thought other situation. And the higher figure respiratory symptoms and correlated with the blood and urine lead level. Of course, lead banning from our study, what we did was lead was banned in India in 1999. And occupation. Children working in the poultry farm, they got 63% of them are asthma, highest percentage. The pet ownership is only 1%. Why it is? Because the bird dropping, they clean twice a week. the fungus will grow on them. They develop fungus allergy. Wheezing is more than 63% asthma. And rag pickers have got the same asthma because of the fungus is grown, the food left over in the rag picker. That's what it is. And also, pets are not the cause of increased prevalence of asthma because our pet in 1979, our 20 years data showed when the Bangalore had a 9% asthma, pet ownership is only 4.25%. Yeah, after 20 years again, we have pet asthma at 25.5% in 2009, pet ownership is on 5.4. I think recently has shown that having 2 pets inside the house, you got less asthma according to GINA guideline. I think we are already using 63% of persistent asthma, stress-related issue. We are recommending them have a pet therapy in certain situation if they're not allergic to that one. And wherever they expose more of the fungus, more of the bacteria in the younger age group, I think they suffer less. And traffic police have suffered more. We know about it. Tobacco smoke, definitely the worst variety. We told if one person smoked, there is 3 to 4-fold increase in asthma in that house. And also our 7.5-year work study showed urban children developed smoking much earlier than the rural children. But after 18 years, rural children suffer the most. And I think tobacco smoke banned our study. I don't want to go in detail. This you already know about it. Diwali time, the asthma 100% increase 3 days. That's mainly because of the sulfur dioxide will be very high, 2 times more than the recommended from the WHO. And to take home message, ladies and gentlemen, high atmospheric pressure over the area correlates with pollution, high pollution at ground level and more asthma. Sunlight and heat produce ozone, produces asthma. Emission, oxides of nitrogen, volatile organic compound, and ozone formation produces asthma, triggers asthma, most the cumulative effect. Increased precipitation, warm air, more moisture, low pressure causes storms, floods, and fungal spores in asthma. Wildfires are increased because of the drought. Asthma going to increase because of the smoke. Increased humidity, definitely increased dust mites and respiratory irritant, extremely irritant. And drought, more smoke, more irritation, more asthma, and pollution. We already highlighted to you about these things. Having said that, ladies and gentlemen, a healthy breath will always bring healthy life. Let each one plant 1 tree and maintain it. It gives oxygen for 4 people. Thank you very much for kind hearing. I have to rush up for a given time.
Thanks indeed, sir, for that crisp and very informative and very interesting talk regarding things of day-to-day importance. Thank you. There is a request from the organizer's side that the question answer session, or rather the question should be asked at the lunchtime. So, thank you, sir.
Sir, excuse me. Sir, just for general knowledge, as you are a world-famed environmentologist, may I know which is the geographical area, which is safest area to have a less impact of environmental on this allergic disease? It doesn't mean that all allergy people will shift there, but just for the general knowledge.
I think many people want to go to Colorado, Denver, Colorado. And I think many of the people say Davos, Switzerland, higher altitude, Poland, and all these things, that they're much less. That's why they prefer that. So I think in available situation, we can live comfortably, sir. Dust mites as a number 1 cause, we heard about it. 60% is from the dust mites, 25% is from the cockroach, and 10% come from the pollens and other irritants and all this thing about 2.5%. These are all the things. I think we have to build our house according to our need. Use Vastu. Vastu is nothing but based on Vedic mathematics. Where the toilet has to be there, where the kitchen has to be there, depend on the airflow, air circulation. Even industries also, we recommend they use this wind flow, and also they have to cover those villages. That's what, as a chairman of the Technical Karnataka Pollution Control Board, I insisted all the industry to spend 1% of the gross profit and net profit to the social cause. They have been doing it. Zindal is the one I would suggest that. 1 lakh acre of the forestry they built. 1 lakh acre. So we cleared their 6,000 crore project. I think they were very happy about it. We suggested they utilized it. And we are very happy. Industry has to grow along with us. We have to recommend. At the same time, guide them how to mitigate that one instead of blocking anything like that. Because the minister sent me, don't clear the file. I said, they have come here technology-wise. As a technical man, I have to suggest. Whether to give a license is your job. My job is to do this one. I think I did it, we cleared it. They're very happy. They always think about it. And I present this data, how the industry, we should encourage, how they can contribute for the social cause. We have done that. They have got a wonderful environment. And also I went to, when I went to WIMS to address a conference, they came to, I came there, they took me, they made me to plant 1 tree in that one. After 10 years, recently I went there, Ballari. There I saw my tree has grown big one. 1 tree, if you grow, it gives oxygen for 4 people. In Bangalore, we had 10 trees earlier per person. We got only 1 tree for 10 people.
Thank you, sir. Thank you.
Thank you. It was great to listen to an initiative taken by a technical expert from our field who has contributed to the well-being of the society. We should clap, we should give him an applause.
Thank you very much. For further proceedings, I would like to request Dr. Smita Desai ma'am and Dr. Vineet Wankhede sir to take over from here.
Very good morning to one and all. A very good morning to one and all. Myself, Dr. Smita Desai and Dr. Vineet Wankhede feel privileged to welcome you all to this August gathering. Occasion is 10th Annual National Conference of Allergy and Applied Immunology, chapter of Indian Academy of Pediatrics, PED ALLERCON, and installation ceremony of PAAI Maharashtra branch. Friends, approximately 20 to 30% of total population in India suffers from at least one of the allergic diseases. Nearly 1.7 million or 18% children suffer from one of the more allergies. Out of this, 15% develop asthmas. Frequency of allergic diseases is increasing day by day. This justifies an urgent need for a strategic and multi-pronged approach to enhance the quality of care for allergic disorders. And this conference is an excellent opportunity to improve our knowledge and understanding about allergic disorders. We look forward to learn from the best of the brains.
Good morning, all. So we all have to invite our dignitaries. It is always a pleasure to honor our dignitaries and invite them on a stage. So we want to give this privilege to our children who have underwent cochlear implant surgery in this hospital, and they will be inviting our dignitaries on the dais. So may I invite first Dr. Vinky Rugwani sir, who is a MMC Maharashtra Medical Council Vice President. Yeah, he is yet to come, I think. Hello. Yeah. I will invite Mohit to invite Dr. Satish Chandra, who is a CEO of Kingsway Hospital. Sir, please do honor the. You are invited to sit on the dais. Yeah. Dr. Ashish Chandra is the CEO of Kingsway Hospital. Yeah. I welcome you, sir. And Mohit will give a floral bouquet to Dr. Ashish Chandra. I request Dr. Sanjay Pakmode, sir, to invite our executive board member, Dr. Sanjay Deshmukh, sir, and escort him to the dais. And I welcome Tanush to give a floral bouquet to our executive board member, Dr. Sanjay Deshmukh, sir. I request Dr. Sanjay Pakmode, sir, to invite and escort Dr. Uday Bodhankar, sir, who is a patron of our national, our Nagpur IAP. We welcome you, sir. We are honored to have a patron of Dr. Uday Bodhankar, who is a past president of CIP in 1993 and is executive director of COMHAD. So please be seated. I request Tanush or Mediha to welcome sir with a floral bouquet.
That's so nice.
I request Pritesh to welcome Dr. Jose Osef, who is the secretary of Pediatric Allergy and Applied Immunology chapter. Please welcome, sir. I welcome you on the dais. So I request Araina to give a floral bouquet to sir. Yeah. So these are the kids who underwent cochlear implant surgery and now they have a remarkable improvement. They are going to sing a song of Vakratunda Mahakaya at the inauguration. So please be seated. I request Dr. Deepak Goyal sir to escort Dr. Sukumaran sir, who is the president of Pediatric Allergy and Applied Immunology chapter, who is the national president. I welcome you, sir, on behalf of the organizing team. He need no introduction. He is an astute clinician and you've been listening to his talks across the various national and international conferences. I request Araina to give a floral welcome to Sir Sukumaran, sir.
Very good.
I request Dr. Kiratkar, sir, who is the president of our Academy of Pediatric Rhinology Nagpur, to escort Dr. Sheila Mathai, madam, who is the lieutenant commander and guest of honor for today's function. It's a matter of privilege for all of us to have her as a guest of honor. She has an outstanding achievement in his career. We all know she need no introduction. Please welcome, madam. Please welcome. I request Snehal to have a floral bouquet to madam. And finally,
I request Dr. Vasant Khadkar sir, who's the organizing chairperson of our PI, to invite and escort Dr. Ramesh Kumar. He's the president of CIP this year 2022. And our chief guest of today's function. So I welcome on behalf of organizing team and AOP Nagpur to have a warm welcome. Later. Okay, I request. Yeah. Okay. I request Dr. Kiratkar sir to honor the podium. Please be seated. Yeah. I request Dr. Kiratkar sir to welcome the secretary, Dr. Krishna Mohan sir, and escort him to the dais. And request both of you to be seated at the podium. Pritish, you be seated. I request Mohit to give a floral welcome to Sir Krishna Mohan sir, who is the treasurer of our national PI. It's the Pediatric Allergy and Applied Immunology chapter, one of the vibrant chapter of IIP. And I request Araina to give a floral bouquet to our secretary, Dr. Pritish Atwar. Pritish, take a floral bouquet.
Thank you so much, all beautiful kids. Okay. So to make this morning a blessed one, let us invoke Goddess Saraswati by lighting the lamp of knowledge and wisdom. Let us pray to Goddess to dispel the darkness of ignorance and lead us to the path of wisdom. For seeking the choicest blessings, I invite all the dignitaries on the dais to join for lighting of Samai.
Yeah. I request all these kids to sing Vakratunda Mahakaya, which they have prepared. So these are the kids who had a bilateral sensory neural hearing loss. They underwent a cochlear implant, and now they can sing the song. We are privileged to hear this. Please give them the mic.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Karma Devo Sarvakaya Sarvada.
Thank you so much.
Thank you.
Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha.
Thank you. Thank you so much. Thank you all. As such, Dr. Vasant Khalatkar needs no introduction to this local audience. He has successfully organized many national and international conferences, and he has innumerable awards and honors to his credit. He has various publications and has conducted many social awareness programs in the last 3 decades. At present, he is organizing chairperson of PED ALLERCON. He was organizing chairperson of National Pedicon in 2018, which we can never forget. We'll remember that conference for years to come. He is chairperson of Academy of Pediatrics Neurology this year and president-elect of Infectious Diseases Chapter 2023. Dr. Vasant Khalatkar, smiling, cheerful, dedicated, and hardworking chief organizing chairperson of this conference, PED ALLERCON, is working day and night to make this successful. I request him to welcome this august gathering.
Before I start, I request Dr. Vinky Rugwani on the dais. I request Dr. Praveen Lad to please escort Dr. Vinky Rugwani. Praveen Lad, please escort. And I request Dr. Pritesh Khatwar to welcome him by floral bouquet.
Please. I welcome you, sir. Vinky Rugwani, sir, is our vice president of Maharashtra Medical Council.
Vinky, please take this seat. Please come here.
I invite Dr. Vasant Khalatkar, sir, to give a welcome speech for this conference.
Good afternoon. Honorable Chief Guest and National President of Central IOP, Dr. Ramesh Kumar, who is from Cochin. Today's Honorable Guest of Honor, Dr. Sheila Mathai, Chairman of PAI and past President, Dr. Sukumaran, who is from Kottayam. My friend, Dr. Joseph, who is the Secretary of PAI and soon going to become chairperson for this chapter. He is from Cochin. Our Sarva Sarva of Nagpur, IAP, our patron, Dr. Uday Bodhankar, sir. My friend, Dr. Vinky Rugwani, honor of Nagpur, Nagpur IAP, our executive board member of Central IAP, Dr. Sanjay Deshmukh. My friend, Dr. Kiratkar, who is the organizing secretary for this conference, Dr. Pritesh Khatwar, who is the secretary for Academy of Pediatrics Nagpur, Dr. Krishna Mohan, Dr. Abhay Shah, Dr. Surendra Nath, Dr. Walwekar, Dr. Arif, Dr. Joginder from Sonpat, Dr. Pandakur, Dr. Chandramohan, who is the CEO of this Kingsway Hospital, all delegates, PG students, and my dear colleagues from Nagpur. Every single moment that happens once in life. I believe it in, and as an organizing chairperson of PED ALLERCON, most awaited conference in Nagpur, I am feeling blessed and fortunate to be here. Actually, this conference was outed in year 2020 in Indore, and we were supposed to do it in December at Nagpur, but because of all this COVID problem, we couldn't make it. But our team, our organizing secretary was sure that we want to make it physical. Kiratkar always बोलता था, sir कुछ भी हो, 4 साल भी लग जाए कोविड को तो भी अपन फिजिकली करेंगे, और नागपुर आईआईपी ने भी उतना ही साथ दिया. So fortunately he became the president, and in his tenure now we got this conference. I really want to thank PAI executive member, office bearer for this keeping the patience and keeping faith on us. God's glory can be seen in many different aspects of his creation, and perhaps the most beautiful of his creation are our children. Pediatricians have been phenomenal since ages, safeguarding the health and happiness of the children. On behalf of the organizing committee, I take this privilege to welcome one and all at the inaugural ceremony of 10th PED ALLERCON at Nagpur. It gives me immense pleasure as I fold my hand and welcome you all. Swagatam, Swagatam, Swagatam. I want to thank Dr. Sukumaran and Dr. Jose for keeping patience for this physical conference. My thanks to today's chief guest, Dr. Sheila Mathai, who said yes to become guest of honor on very first call. No, ये word ही शीला मैडम को मालूम नहीं. It shows her affinity toward Nagpurian. Thanks, respected Dr. Parmesh, who is the patron for his gracious presence. How can I forget my friend, Dr. Ramesh Kumar, who traveled throughout night from Cochin to Nagpur. He had a sleepless night yesterday, but because of rescheduling of all his flight, he has to keep awake throughout night. This shows his love, affection, and responsible behavior toward IAP and IAPians. Thanks, dear Ramesh. There are lots of things to learn from you, Ramesh, and I am learning that. In these 3 days, faculties from all over India showing their knowledge. Hats off to you all faculties. Thank you. This conference was a dream project of our organizing secretary, Dr. Kiratkar. He worked day and night in spite of few hurdles to him. Success of conference totally goes to Dr. Kiratkar. Thanks again, Rajkumar. I must say thanks to scientific chairperson, Dr. Kuldeep Sukhdeve, in crafting excellent scientific program. We never forget Dr. Bodhankar, who always stood with us as a backbone. The day when bid to ALLERCON in Indore was won was a memorable day in a book of my life. We started working, and with our chief organizing secretary and team become busy in planning and visualizing to organize ALLERCON in Nagpur. I was hunting for high-tech and centrally located place in Nagpur to deliver ALLERCON. As if my prayer was heard and Kingsway Hospital come into existence. This beautiful auditorium of Kingsway Hospital was selected as a venue. I am grateful to Dr. Ashish Chandra, CEO of Kingsway Hospital, for being so generous to grant us auditorium. This unique conference is possible because of great help extended to me by my fellow Nagpur IAPians, along with guidance from time to time. Thank you. I'm sure that through ALLERCON, we will spread knowledge, update our academic skill, create new horizon. The only code of conduct assigned to our team, ALLERCON, was better academic and unmatched hospitality, which my fellow colleagues have followed religiously and made this conference what it is seen today. We believe in Atithi Devo Bhava, and as a host, these 3 days, we promise we will provide those little extras that makes a big difference. Yesterday's workshop was too successful. Thank you to all delegates. We have tried to anticipate your need and exceed your expectations. I invite you all today evening for grand banquet. We have invited prominent national speakers to share their knowledge and experience in the field of allergic diseases in children. The conference will highlight current issues, challenges, trends, research, guidelines, and experience sharing opportunities in pediatric allergies. Please grab this opportunity. At this moment, I express gratitude to my teachers and friends who made me what I am today. My patients who bear me. Dear friends, your names are engraved in my heart. I can't just say love you, and love you. Once again, I welcome all the delegates for this special event and wish you fun-filled academic bonanza in this wonderful session. Jai Hind, Jai IAP. Thank you so much. जाते जाते रिमझिम गिरे बारिश की फुहार, रिमझिम गिरे बारिश की फुहार, दोस्त मिले तो आए जिंदगी में बहार. पेड ALLERCON लेकर आया है एकेडमिक का त्योहार, जहां हम सीखेंगे एलर्जी का उपचार. Thank you.
Thank you, sir. Thank you for that warm welcome to all our dignitaries. We always see him as a man of foresight who can do a Herculean task of organizing PEDCON, but also the CMEs at a national and local level. Yes. Thank you, sir.
Today, we are privileged to have Dr. T.U. Sukumaran, sir. He is National Chairperson of PED, one of the most popular and highly acknowledged pediatricians of Central Kerala, with more than 40 years of experience in pediatrics, childhood asthma, and related diseases. Government of Kerala honored him with Best Doctor Award in 2022 for his meritorious service to the Kerala's private healthcare. I welcome Dr. Sukumaran, sir, to give his presidential address.
Beloved Chief Guest of the Day, and my beloved friends, students, and colleague, National President of Indian Academy of Pediatrics 2022, Dr. Ramesh Kumar, my close friend, and the past President of Indian Academy of Pediatrics, 1993, Dr. Uday Budangar, sir. I think he is the youngest person to become the National President of Indian Academy of Pediatrics. And also I am very glad that he was also a JC also. I still remember he got the Outstanding Young Person Award of the World. And I was also a part of that. So he is also here. And my close friend and neonatologist, Dr. Sheila Mathai. Now Sheila Mathai is the Director General of Neonatology for Armed Forces Services at New Delhi. Beloved Madam, very, very happy to be here with you and welcome you for this conference. And also I have great pleasure to be with Dr. Vasant Kalakar, who is an youngster, active, very active pediatrician. And when I was a national president in 2011, he was also the executive board member of Indian Academy of Pediatrics. And he is the chairperson of the two chapters, ID chapter and neurology chapter. And I wish Dr. Vasant Kalakar all the best in the years to come. And all the other dignitaries on the dais and off dais, Dr. Patel is there, and my beloved mentor, Dr. Paramesh sir is also there. All other brothers and sisters of Indian Academy of Pediatrics and my dear friends. It gives me great pleasure and privilege to be here with you to participate in the inaugural function of the PED ALLERCON organized by IAP Nagpur in a wonderful manner. I want to congratulate the organizing chairman Kalakar and also the organizing secretary Rajkumar for organizing this wonderful conference. And please give them a loud round of applause for the excellent arrangement they have done. And going to the program, we have got a hectic program. We have got a galaxy of speakers from India and outside of the country. You might have heard the excellent talk by my beloved friend from Singapore and also from US also. So excellent faculty of national and international repute is there. And also our own Paramesh sir is there to talk on various aspects of allergy and immunology. And this conference is going to be very beneficial to the practicing pediatricians, allergy specialists, and postgraduate students also. Coming to our activity of Pediatric Allergy Association for the last 2 years, because of the COVID pandemic, we could not do so much of the physical meeting, but we have done a number of Zoom meetings done. And also we have conducted 2 national conference, and last national conference was a hybrid meeting, which was conducted at Kottayam. And it was a wonderful conference. And other activity I want to highlight is one that we have released a book on textbook of pediatric allergy and immunology. It was released 2 years back, and it was distributed free of cost to more than 1,000 pediatricians throughout the country. And also we are conducting a Zoom meeting on last Friday of every month, and it is continuing now. But the most unfortunate thing happened for Pediatric Allergy Association last year, because Pediatric Allergy Association, all the works were done by a trio, Dr. Paramesh, Dr. Nagaraju, and myself. Unfortunately, Dr. Nagaraju had a sudden demise, due to COVID, very early, unexpected demise of Dr. Nagaraju. We are very much unfortunate that he has gone, and he was the key person to start Pediatric Allergy Association of India, and this association was launched in 2010. In 2010 at Hyderabad, when Deepak Kugra was the national president, and I was the president-elect of Indian Academy of Pediatrics. And with the great work of Dr. Parmesh and Dr. Nagaraju, this group, this chapter is going higher and higher. And I wish that when Dr. Jose and Krishna Mohan are taking over, I think it will become further one of the biggest chapters of Indian Academy of Pediatrics. Once again, I wish all the best for this conference. And I congratulate the AAP Nagpur for the outstanding performance they have done. Thank you, AAP. Thank you very much.
Thank you, sir. So Nagpur AOP is privileged to organize this national conference, and thanks for the confidence you have bestowed on us. Now I invite Dr. Vasant Khadkar sir, Dr. Ramesh Kumar sir, and Dr. Kiratkar sir to honor Dr. Sukumaran sir with the shawl, Shrifal and memento. Dr. Bodhankar sir, please accompany to